Welcome and good morning. I wanted to thank you all for joining us. So today we're going to have an ultrasound guided interventional pain and regional anesthesia course. I have Dr. Gary Esses assisting me, so thank you, Gary. And as you are joining still, we have about a third of the docs here. I'm just going to go over some of the survey results, and then we'll get started because we have a lot of content to cover. So it looks like most of you are anesthesiologists and almost 80% of you are pain physicians. And the content that you requested that I focused on mainly would be nerve blocks, then to a lesser extent, joint injections and fascial plane blocks. I will be doing other webinars in the future with more focus on the fascial plane blocks, but I do have quite a few here today. And most of you are interested in private training, so if individually or in a small group you're interested, just shoot me an email afterwards. And the replay will be available. This will be emailed to all of you. So I'm going to get started, and those who did not join yet can just catch the replay because we have a lot of content. So the first unit is going to be ultrasound upper extremity nerve blocks. Here are my disclosures. These are companies that I speak for. However, they are not going to be relevant for today's talk. Excuse me, end the poll. Okay, just getting set up here. Just going to share my screen. Give me a moment, please. Okay, and for CME credit, 4 credits are available through my hospital, Maimonides Medical Center. You just need to text 79 SORD to the number below. And if you have any questions at any time, feel free to send me a message with the chat, and I'll be more than happy to answer your questions. Okay, before we begin, I'm just going to make sure no one else is struggling to get into the course, and we'll go on. Okay, looks good. So the progression and signs of and symptoms of local anesthetic toxicity. I'm starting with this because if we're going to be doing these nerve blocks, I think it's very important that we all are aware of what to look for when we suspect a local anesthetic toxic reaction and how to treat it. So the complaints the patient may have vary from vertigo, tinnitus, ominous feelings, circumoral numbness, garrulousness, tremors, convulsions, coma, and cardiovascular collapse. The initial presentation is typically confusion or obtundation. First thing you want to do is stop the injection. Ask for help. Consider lipid emulsion therapy at the first signs of a serious local anesthetic systemic toxic event. If you're working in an office using high doses of local, you should have the kit there. If you're only giving 1 or 2 mLs and you're in an orthopedic practice or somewhere else, I wouldn't worry about it unless you're doing shots that are very close to major blood vessels, such as in the neck or intercostal nerve blocks. If you suspect if there is a cardiovascular collapse or you need to resuscitate the patient, ask for EMS to take the patient to the hospital with the nearest bypass team, because of this may be a prolonged resuscitation. The bupivacaine binds to the cardiac cells, and therefore it can take a long time to disassociate. Intralipid can act as a substrate to reduce the binding and help with the patient's resuscitation. Of course, airway, circulation, breathing must all be taken care of, not necessarily in that order. And if the patient is seizing, or if you think they may have a seizure, make sure that you're controlling for it. In this case, benzodiazepines are preferred because of the hemovascular collapse that can occur with a propofol bolus. Okay, so for patients greater than 70 kilograms, you can bolus 100 milliliters of lipid emulsion, 20%, rapidly over 2 to 3 minutes, and then an infusion of 200 to 250 milliliters over 15 to 20 minutes. If they're less than 70 kilograms, bolus 1.5 milliliters per kilogram lipid emulsion over 2 to 3 minutes, then an infusion of about 0.25 milliliters per kilogram of ideal body weight per minute. If the patient is still unstable, rebolus once or twice at the same dose and then double the infusion rate. There is a dosing limit of 12 milliliters per kilogram. The total volume of lipid emulsion can approach 1 liter in a prolonged resuscitation. This is over 30 minutes. And then you continue monitoring at least 4 to 6 hours after the cardiovascular event, or at least 2 hours after a limited central nervous system event. And these limitations for the doses are especially true with children. And go to the ASRA website. That's where I got my information. They have a lot of useful information with respect to this. Okay, so when we're talking about ultrasound-guided nerve blocks, if you are an anesthesiologist like myself, you've probably been caught in the operating room when the surgeon goes to make incision and he starts and the patient feels pain. I don't like to admit it, but it's happened to me. I'm sure it's happened to most of you at some point. So why is this happening? Well, one, because it could be you just don't know what you're doing, but more likely, if you do know what you're doing, there's a septa forming subcompartments, and there's fascial membranes preventing spread. You may think you're next to the nerve or target tissue, but there's actually a piece of tissue or a membrane over the nerve that's preventing spread upon that nerve. You may be injecting into the body of the muscle. For instance, if you're doing a scaling brachial plexus block, an interscaling brachial plexus block, you may have accidentally gotten the local anesthetic into the muscle, or better yet, if you're doing a TAP block, a transverse abdominis plane block, the fascial covering of the muscle may be, the needle is between that fascial layer and the muscle itself, as opposed to between the two fascial coverings in the TAP plane, in the transverse abdominis plane, in between the fascia. You may not be doing your knobology, your focus may be incorrect or not clear. And maybe you're injecting all the local anesthetic in one spot and it's not completely anesthetizing the nerve. So other reasons for failure: if you're oblique, if your probe is oblique, you may not be seeing your needle tip, and you may think you're seeing your needle tip. As you see here, the image on the left, you're out of plane, but you may think you're in plane because you may actually see a line here on the ultrasound screen. Whereas if you know you're out of plane, you may just see a dot representing the needle tip, but you may not know where along the shaft or the tip that dot is. Okay, the brachial plexus. If there's any questions, feel free to ask in the chat room. This is a very big part, very important part of this course. The brachial plexus, as you should know, covers the upper extremity. It's divided into the interscaling, supraclavicular, and infraclavicular regions. The axillary brachial plexus is really not considered the brachial plexus by many because the nerves have already branched out at this time. The axillary nerves, as you can see, consist of the muscutaneous, axillary, radial, median, and ulnar. Not to be confused, the axillary nerve and the axillary brachial plexus, okay? You have the interscalene, more proximal, supraclavicular, infraclavicular, then axillary. So Rod Taylor drinks cold beer. Roots trunks at the interscaling, divisions at supraclavicular, cords at the infraclavicular, and branches at the axillary brachial plexus. The interscaling block will provide anesthesia of the shoulder, lateral clavicle, acromioclavicular joint, proximal humerus, and lower arm past the elbow, excluding the ulnar nerve. It can be used for shoulder pain, whether pre, peri, or postoperative. It can be used in the pain office for brachial neuritis, which we'll get into soon. It can be used for frozen shoulder or manipulation of that shoulder to reduce adhesions or just the pain of it. And as mentioned, the ulnar nerve, which gets its innervation from the lower cervical and T1, is not reliably anesthetized because it does not join the brachial plexus at the point where you're getting the nerve block done in the interscaling fossa. If you see here, we have the nerves lined up between the anterior and middle scalene nerves. That's sternocleidomastoid, and here's probably C5, C6. The lower branches, C7 is not visible here, C8, T1 are not yet part of this brachial plexus bundle, and therefore they will not be anesthetized if you inject this area. In the past, when I was training, we did everything blind or with a twitch monitor. It was in the middle of my training that we started using the ultrasound, and I started using the ultrasound as a resident in Bellevue when we were doing of course, the regional procedures, but especially the hand procedures. We had a very busy hand service in which we would have patients who were they were trauma patients who were injured their hand. They had a lot of amputations, and the surgeons were doing anastomosis of the nerves, of the blood vessels of the hand. It was a 20-hour surgery. They would check pulses on the floor, and the patients would come back to the operating room to get re-anastomosed or for other reasons. And we put infraclavicular nerve blocks in these patients with catheters, and we would rebolus the catheter, and this helped us get the patients through these very long and difficult surgeries. So what we were doing in part of my training was the interscaling blocks. One of my attendings was doing it just by paresthesia technique, which you can imagine how dangerous or uncomfortable that could be for the patient when you're just taking a needle, maybe blunt, and you're just poking a nerve trying to get paresthesias, or the twitch monitor technique, which I used to work at hospital for joint disease, and the docs over there did a fantastic job without that, but they still weren't using ultrasound. It was at Bellevue where we were using the ultrasound, and we brought this to the other hospitals in the NYU system, and it spread from there. However, when I was in my pain management fellowship, ultrasound was not there. It was a fluoro-based traditional pain fellowship, but there was a lot of encouragement to explore, to learn, and therefore I integrated ultrasound into my practice as well as an anesthesiologist, as well as a pain doctor. So you can imagine doing the blind approach may not be the safest or accurate way to treat your patient, especially when you're close to a blood vessel or the intrathecal space. And in the interscaling brachial plexus, you're close to both. So this is a parasagittal cross-section where you see the interscaling nerves between the anterior and middle scalenes, subclavian artery, and the subclavian vein. Here's the lung. And you can see the problem with this block is you have the vertebral arteries a little more posterior, which aren't shown here, the dome of the pleura. The cervical spine also you can't see here. However, there are reports of injection and anesthetizing the nerves, the cervical nerve roots, as well as spread to the cord or blood vessels in case reports of complications from interscaling blocks. And you have the internal jugular vein. So I think those are all enough reason to do this with ultrasound. I don't think I need to convince you. So looking here, we can surmise this is the C5, 6, 7 nerve root. You have the scalene muscles on either side. Now here you have an ultrasound probe that's being positioned on the neck, looking for the interscaling nerves. And you're changing the position to get the supraclavicular nerves, which is right above the clavicle, and here's the subclavian artery. Here is the brachial plexus right here. And then the probe is going to scan back up again. By the way, this is the lung under here, first rib. And moving the probe back up in the neck, you find the interscalene nerves again. Okay, C5, C6, C7, possibly C8 joining. Okay, anterior scalene, middle scalene. So with the ultrasound, you have less tissue disruption for repeated needle passes, and you don't need such a high volume of local anesthetic as you do with the blind techniques or twitch monitor. You can see all the structures if you need to reposition. You can see how your local anesthetic spreads, and you can also use Doppler to identify blood vessels and make sure that your needle is not in or too close to a blood vessel. So once again, locating the interscalene nerves. Here's the trachea, the thyroid, carotid. We're going lateral, sternocleidomastoids above, and we're finding the interscalene nerves lining up. The probe is basically coming here and moving lateral. Okay, there's the brachial plexus again. And I'm repeating this because it's very important to get used to the way things look here. Now, I'm scanning upwards here and backwards, and you can actually follow the cervical nerve roots as they go into the foramen. And this will be relevant for you pain docs later on when we talk about cervical radiculopathy. So you can also start from the supraclavicular space, as I did in the previous video, which is over here for those of you who don't know or forgot, and just scan upwards. That's another way. It's very easy to find the nerves when you find the subclavian artery, and you just follow your way backwards. Okay, once again, sternocleidomastoid, anterior scalene, middle scalene, or medial scalene. That's the position of the probe. You have a groove that you could feel on yourself. It's a very annoying place to touch between the scalene muscles. That's your brachial plexus. So when you're doing these nerve blocks, it's always good to focus on the nerves. Don't worry too much about finding the interscalenes. You want to find the hypoechoic, which means black, circular structures lined up like this, usually 3 or so, give or take, because there are variants, and that is your target. For those of you who are very experienced with regional and have very good needling technique, you could actually stick a needle between the nerves and then move it back to each side and get local surrounding each nerve for a very good block. If you're not so confident with your skills, sometimes it's enough just to get the needle close enough over here or up top here. Just make sure when you're injecting, first you aspirate, there's no blood, but second of all, that you watch the local dissect around the nerve and that you're in the proper compartment. Because if you get over here and the local spreads into the tissue this way, it's not going to help you. And there could be adverse effects, such as the phrenic nerve, and other nerves can get anesthetized that you did not intend to. The phrenic nerve does get anesthetized in most cases of interscalene nerve blocks, and patients will present with shortness of breath when this happens. Okay, so there are variants. C5 or C6 may actually pass through the belly of the anterior scalene muscle. It may look like actually a hole inside the muscle, a black hole in the muscle. It could appear as a vessel, but you should put some Doppler on to make sure that there's no flow, and you should be okay. When you want to inject it, just make sure your needle is not in the nerve, of course, but right around it. So you need to be very good with your ultrasound needling skills. And there are a few tricks to help you with this. One is practicing on a phantom. The other is learning to be ambidextrous when you train, as well as keeping maybe one finger on the probe or your other hand while you're needling so that you can actually move everything as one unit. Okay, so for you pain docs, in the pain office, there are a lot of evidence-based reports, studies, showing cervical epidurals help, and they do. However, you're near the spinal cord, so I try to avoid them when I can. Brachial neuritis can be treated in many ways. Brachial neuritis is inflammation or pain of the brachial plexus. It's the same CPT code as cervical radiculopathy, M55.12. So in terms of your billing for this, typically the payers do not have a problem with you seeing someone who presents with pain over here, signs of cervical radiculopathy, but they happen to have a TENELS or pain when you touch the nerve in the interscalene or supraclavicular fossa. When the patients present like that, and even though it may be an axial source, but they're having some sort of hypersensitivity, more peripheral, many times, believe it or not, they will respond to an ultrasound guided injection of either the brachial plexus at the interscalene or supraclavicular fossa or a supraclavicular nerve block. And there may be many reasons for this, but there have been reports in the literature of peripheral injections helping with proximal or central axial problems. And I've seen it in my practice many times. And I've talked about this many times on the podcast as well. So patients will often present, oh, I have a cervical radiculopathy, and they'll touch themselves right here. We do have a question from one of the docs here who's asked me what type of needles I'm using for the procedure. Great question. If I'm an anesthesiologist in the operating room, typically it will be a blunt needle, maybe a Stimiplex. Even though I may not be stimulating, it's just that style of needle. 21 gauge, I believe, or 20 gauge. If I'm in the office, the pain office, I almost exclusively for these shots use a 25 gauge needle. Now, this is a sharp needle. I've been doing this for many years. There are some reports saying not to use a sharp needle. But what I find with the 25 gauge needle, the 25 gauge 1.5 inch, meaning that's that needle used for your skin wheel for epidurals, or the needle that's the blue spinal needle, the 25 gauge 3.5 inch needle, it's less painful for the patient because it's not blunt. It just goes through the tissue much smoother. And it also, if you practice as long as I've been doing this, I've been doing this 13 years, I usually can see it very well. And I've never had a nerve injury from it. Now, I'm not saying you won't. Logic dictates it is a sharper needle versus a blunt needle. So I'm not telling you to use a sharper needle when you're doing nerve blocks because you may get into trouble and I don't want you blaming me. However, this is how I practice. And thank God I've had a very good track record. And I believe there's a higher patient satisfaction when the procedure is not as painful. I'm not saying it doesn't hurt. It can still hurt. So the interscalene and supraclavicular brachial plexus blocks can be used for manipulation under anesthesia. Let's say there's adhesive capsulitis, or the orthopedic wants to take the patient to the propofol. Excuse me. Or orthopedic wants to take the patient for manipulation to the OR. They may ask you for propofol to manipulate, but an interscalene would probably be gentler and nicer for the patient. I've also seen it happen with the physical therapists. When you're doing a biologic or for instance, a bone marrow aspirate mesenchymal stem cell procedure or PRP procedure, and you don't want your local anesthetic to mix with the biologic that you're injecting, because PRP, for instance, there can be an impairment of platelet function with the local anesthetic. So it may be desirable to do a nerve block more proximal, like an interscalene nerve block, when you're doing the procedure to anesthetize the patient. The CPT code for this is 64415. And oftentimes, if I'm doing this in the office in interscalene, I'm using low volume, low dose of bupivacaine. And I'm not trying to get a surgical level here. I'm trying to get the patient out of pain. And typically, I would add dexamethasone, 2 to 4 milligrams to prolong the effect. I've had many patients come to me who 99% of the pain doctors in the world would, or in America at least, would do an epidural steroid injection. And I've given them an interscalene nerve block. And these patients, believe it or not, have not gone on to need an epidural or surgery. And you ask why are you doing intercostal nerve block in the office? You can get phrenic nerve paralysis. Well, I'm using very low volume, and as I mentioned, low concentration. Sometimes I'm diluting with saline, and I'm observing them afterwards. None of them have hemidiaphragmatic paralysis beforehand. If they have COPD, I'm usually not doing it, or I'm doing something different. So I'm being careful. I'm screening my patients. I'm not just blindly doing this, expecting everything to be okay. I do have resuscitation equipment, monitors in my office. However, I've never needed to use them after this procedure. If a patient gets a phrenic nerve block after an interscaling block, well, if they're under your care in the operating room or the perioperative period, typically we treat them with reassurance because it's usually just a subjective shortness of breath that will resolve with a tincture of time. However, if it's something more, if they're really panicking, if they're under your observation, we've given midazolam for the anxiety component of the shortness of breath, which you normally would not give a patient with shortness of breath midazolam, right? But this is something that you're watching them. You have airway equipment. This is in the operating room. In my office, I'm not doing that. If they have shortness of breath, I've never seen it actually, but they're getting observed. I've never seen shortness of breath after an interscaling block in my office. Now, I don't do this every day, but I do it every so often when I feel that the pain is coming proximal. Oftentimes, I'm doing the selective nerve root block with a lower volume, and I'm tracing up from the interscaling nerves, which we'll get into later. Okay, once again, here's an idea. You see the cervical nerve roots exiting the spine, how they come together in that classical location where the patient reports pain when they have a cervical radiculopathy. And once again, in case you forgot what the last 4 pictures of the interscaling block look like, you have it right here. This is a larger patient with a thicker neck. He had surgery, posterior and anterior cervical surgery with fusion. There was no way I was doing an epidural in the back of his neck because he had a large scar in the back of his neck. He had pain right here, radiating down his arm, and he had a cervical radiculopathy with an interscaling block, and he did great. He did have atrophy of his left arm prior to the block, as well as tunnels over the interscaling fossa, right here. Okay, and here you see the ultrasound movie, and there is a needle right here coming in, and it's getting right above the plexus. Perforating that fascial sheath around the muscle and injecting. Okay, the supraclavicular block, it can anesthetize the shoulder, but usually not reliably. So it depends really on where you hit it because you have the suprascapular nerve coming off more proximal. So if you're too distal, you will not get the suprascapular nerve, and you may need to supplement if you're doing something in the shoulder, or you just don't do it. Do an interscaling if you want the shoulder. But it is a pretty reliable block for anything distal to the shoulder. It can treat brachial neuritis. The CPT code is the same thing, 64415-76942. And if you are a pain doctor, these blocks are very important because of course, because of everything I'm saying for the patient's benefit, but it's also important for your practice in terms of when you get into peripheral neuromodulation. It's very important to learn how to identify these structures and anesthetize them, as well as when you are talking to spine surgeons or orthopedics who say, I don't like cervical epidurals, they're too dangerous. You're giving them more options. And I think your patients also appreciate that as well. Once they truly understand what a cervical epidural is and what is the worst case scenario from a cervical epidural, it only happens in a few patients every year. However, if enough physicians can move to these blocks prior to the cervical epidural, those complications can be reduced. And those complications, as you know, can be quite devastating, quadriplegia or death on injection. Okay, once again, that picture of the parasagittal region, and I brought this up because it's basically the border of the interscaling and supraclavicular fossa. Subclavian artery is the key landmark. You have the insertion of the anterior scalene into the first rib, which lies between the vein anteriorly and the subclavian artery posteriorly. On the ultrasound, the vein is well forward of the artery and is most of the time hidden below the clavicle. Okay, This is what it looks like. It's not as easy to identify the different divisions of the brachial plexus. There's tons of anatomical variations. And what I could say is if you scan from medial to lateral along this and maybe a little bit posterior, you can actually see the takeoff of the suprascapular nerve, which if I had to guess here which it would be, I would say it may be one of these nerves on top. And it disappears by the suprascapular notch. Below this is the lung. So this is a movie I created. Some of you have probably seen this already, especially those of you from my department who are watching this. But it kind of goes over my way of doing the supraclavicular nerve block in the office versus the way they do it in the operating room. And the reason I bring this up is I think it's quite important to show the different approaches and the considerations. In the operating room, you're using a large volume of local. In the pain office, I'm using a smaller volume and have the patient sit up. Never seen a vasovagal from this. I'm also not giving 30 mLs of local here. I'm giving this block of bupivacaine for a patient who's undergoing a shoulder stem cell procedure. And as you can see, I'm using a 25 gauge, 3.5-inch needle, and I can see it quite clearly. The artery is forward, the lung is underneath. As long as I could see my needle like that, there should be no reason to get an intravascular or pneumothorax. You're not near the phrenic nerve, so that shouldn't be a problem. And if I was to go in too far, I would be above the artery and I would come out through the front of the patient as opposed to the patient's lungs. And this is where a pain physician differs from the anesthesiologist. I'm not saying anesthesiologists are wrong, because if you're giving 30 mLs of local, you might want that patient supine. However, in the anesthesia world, we aim towards the lung, which can be quite dangerous, especially when you have people who are not used to doing the nerve blocks and are not able to find their needle tip. So once again, it's a reliable block. You avoid the phrenic nerve, and that can be beneficial for patients with COPD. Of course, there still is a risk of pneumothorax if you're not careful, intravascular injection. And it's great for procedures distal to the shoulder. And the needle does not need to be redirected many times, meaning you get into this compartment with the needle, and oftentimes one injection is enough to get all of the different divisions of the brachial plexus. And here in this picture, you could see how the nerves are spread out and the arteries right next to it. Okay, once again, in case you forgot from your internal medicine days, this is what a pneumothorax looks like. You may need to read this at some point. And here you see healthy lung tissue all the way out to the sides. Here the lung is contracted, and this is just empty space. So once again, keep the needle in plane with your beam. That's why you need to practice this. Always go slow and inject slowly, especially if you're giving a large bolus of local anesthetic. Okay, the infraclavicular brachial plexus block. This is the block I grew up on at Bellevue when we were doing those hand surgeries. One of the great things about this location is that it has a very low uptake of local anesthetic. In my training, we were giving patients 40 mLs of a mixture of 2% lidocaine, epinephrine, and bicarb. Now, if you do the math, that's an overdose. With epinephrine, 7 to 8 milligrams per kilogram is the max. 490 on an average 70 kilogram patient. We were giving 800 milligrams of lidocaine. Why didn't we kill anyone? Well, there is a low uptake of local anesthetic in this region. Even with epi, we were giving a lot. We used bicarbonate to hasten the onset, and then these patients would get a catheter. Now, this is about 15 years ago. I don't know if they're still doing this at NYU, at Bellevue, but this is what we used to do. It worked very well. And we placed catheters in these patients, which we run a bupivacaine infusion. So this is not such a common thing I do in my pain practice. However, if I was to consider maybe peripheral neuromodulation, this may be an ideal spot because the catheters tend not to move. We would typically place a catheter between the posterior and medial cord for an infusion. It looks quite scary when you put a probe here and you take a needle and you just aim straight down. But you're actually lateral to the lung if you're doing this properly. I remember people watching me do this block and getting a little anxious over it, but you're not near the nerve, near the lung, if you're doing this the right way. So it's a pretty safe, easy block to do, low risk of pneumothorax. This is a slide I created to give you an idea as to when a high versus a low frequency ultrasound may be available. Now, there is an introduction ultrasound lecture that I have. And for those of you who are beginners, I can try to send it to you to go over the concepts of ultrasound. As you know, I just got into everything today without explaining the theory of ultrasound and how it works. So if you're a beginner, some of what I'm saying may be a little bit above your head, but we are going to go over some more basic procedures such as knee injections and soft tissue injections if you're not going to ever use the infraclavicular brachial plexus block or any of these other more advanced pain procedures. But for those of you who have the option to have a high or a low frequency probe, I generally recommend a high frequency probe for almost everything I've mentioned today, except for possibly the infraclavicular brachial plexus. And that could change depending on the patient, meaning if it's a larger patient, use the higher frequency probe, the lower frequency probe for greater depth penetration. The other advantage to the low frequency probe is it's curved, so you actually can have more room for the needle to go between your clavicle and the probe, whereas with the flat tipped high frequency probe, it may be more difficult. Now, the chords are hyperechoic. You have the lateral chord, more commonly cephalad, the posterior chord, which is posterior to the artery, and the medial chord is typically between the artery and vein. And you can see here how the chords went from being hypoechoic to being hyperechoic. They changed. The density and the water content changed as the nerves left the cervical spine. Here you have your pec major, pec minor. And when you're doing the block, your needle is going to first anesthetize the medial cord, pull back, redirect, get the lateral cord, pull back, and then change your angle, go behind the artery at 6 o'clock, and then you can inject for the posterior cord. And if and when you're placing a catheter, you're going to actually place at that last location that I was describing. So here is the comparison between an older, lower frequency model, which is what I used to use at Bellevue all the time, and the higher frequency. This is not an obese patient, so the high frequency looks great. You're not that deep. You can see all the tissues quite clearly compared to the grainy looking lower frequency probe. There are lower frequency probes which are better, more modern ones. But this is just to give you an idea as to the differences in the image as well as the shape of the probe tip. Okay, the axillary brachial plexus here. You have the median radial and ulnar nerve that lie around the axillary artery. The radial artery is deep to the axillary artery. This is a board's question for anesthesia and possibly on pain when they start to ask about ultrasound, which I think will eventually happen if it didn't start yet for the boards. The muscocutaneous nerve is usually easy to find. You're just going to take your probe and just slide it a little bit more distal into the coracobrachialis muscle body. Cross section of the nerves here. You have the artery, the radial nerve, once again, deep to it. The median nerve is over here. This is an easy block to perform. The ulnar nerve is more lateral, or inferior, I should say. And once again, you want to get the muscocutaneous nerve in the body of the coracobrachialis muscle. A long time ago, before the ultrasound, we would use the blind method where we get the patient's pulse, stick a needle, aspirate blood, go past that blood vessel, aspirate, and if there was nothing in the aspiration, you'd inject, pull back, get the blood again, and then when you pulled out of the artery, there was no blood to aspirate, you would get you would inject the medication. Once again, this is the position. Usually the patient is lying down on the bed like this, on the table, and their arm is abducted and supinated. This was the best picture I can find, so it kind of gives you the idea of what I'm talking about, even though it's not exactly, the patient is not standing up for this. So you want to just place the probe get a cross section of the artery when you're doing this, and the needle's coming from above. And the artery can be identified by pulsations and the resistance it has to collapsing. So once again, here's a picture of the axillary brachial plexus. The nerves, the muscocutaneous nerve is in a separate compartment that needs to be blocked. Lateral to the artery, you have the median nerve. The ulnar nerve, I must correct myself, is more medially. Or if you're coming from above, it's more inferior, right? Okay, here's a video of the axillary brachial plexus block. High frequency ultrasound probe, the artery, ulnar nerve. That would make this that's the radial, right, deep to the artery. What would this one be? Median. And then you need to find the muscocutaneous nerve in the coracobrachialis muscle, which is right here. This is an older ultrasound machine, so the picture's a little more grainy. This is the humerus. And the artery is off to the side, which you don't really see well here. Once again, just to go over the anatomy, we've covered the ultrasound, infraclavicular, supraclavicular is not really shown here. You can see here how the axillary brachial plexus will come to the mid-humerus level. It can be blocked over here. I do not get into it so much on this course. In addition, we have the lateral pectoral nerves. You have other nerves which are blocked with other types of fascial plane blocks. And I'll go over these in future courses. I'm not getting into everything such as the pecs, the peng. I'm not doing that in this course. The radial nerve. So the radial nerve, believe it or not, I do block every now and then in my office. You may need to block it as an anesthesiologist for supplemental anesthesia. It leaves the axillary artery with the profunda brachial artery in the axilla to innervate the triceps muscle. The profunda brachial artery follows the radial nerve as it moves from the axillary artery towards the spiral groove of the humerus, which if there's a humeral fracture, the radial nerve can be damaged. And here you have the radial nerve arising from the posterior cord of the brachial plexus, innervates the extensor supinator muscle group, and provides sensory innervation to the posterior aspect of the elbow, forearm, and hands. Radial nerve at the wrist. Okay, it's usually running next to the artery. It's very small, can be injured when you're doing an arterial line. That's why it's a good idea to use ultrasound when you're doing your A lines. I also, in my office, occasionally will block the radial nerve under the brachial radialis. Every now and then, the patients will get inflammation of the nerve, and for various reasons, there'll be maybe an entrapment. There will be radiation down towards the thumb, and they will respond very nicely to a small injection under the brachial radialis, under ultrasound, depositing a small dose of local anesthetic with steroid. Typically, when I do nerve blocks, I don't need more than 10 to 20 milligrams of depomedrol steroid, or 2 to 4 milligrams of dexamethasone. Most studies that I've read show that above 4 milligrams of dexamethasone, there's no added benefit. Okay, the median nerve formed from the medial and lateral cords. There's no branches to the arm. It's superficial to the axillary artery in the axilla. It crosses the front of the artery from lateral to medial. It can be displaced to either side from the axillary artery with transducer compression. It descends between the heads of the pronator teres. You've probably heard of pronator teres in impingement syndrome. It gives rise to the palmar. It gives off the palmar cutaneous branch, and it passes below the flexor retinaculum. When you're doing a injection in the cubital fossa in the elbow, it's a 64450 code. But if it's at the carpal tunnel, it's considered a carpal tunnel injection, and it's at the carpal tunnel sheath. 20526 is the code. Okay. So carpal tunnel syndrome, median nerve entrapment at the wrist. The symptoms are typically exacerbated with wrist flexion. You have Tinel's by touching the nerve location of entrapment. You'll exacerbate the symptoms with numbness, paresthesias, radiating. The median nerve is, this is proximal to the carpal tunnel, so you don't really see the tunnel so well, but this is one way you can get the block done. If you get in the perineural space, it will help the patient in most cases. Here you have the flexor carpi radialis tendon, the flexor carpi digitorum superficialis tendons. Now, if you're an anesthesiologist, most of these hand surgeons like to do this block themselves. However, you could do it for the case if the surgeon is on board. In the pain office, I've injected local anesthetic with steroid as well as PRP for this type of injection. So here's just a cross-section of the nerve. I'm coming in with a needle, 25 gauge, 1.5-inch needle from the side. And the key thing here is the hydrodissection. I'm dissecting around the tendons here. That looks like a nerve, it's actually a tendon. One way to distinguish the nerve from the tendon is have the patient wiggle their fingers. The nerve typically will not move. And I'm hydrodissecting to make room for my needle. And I'm injecting. I got into the neural compartment, not into the nerve itself. It may look like I'm in the nerve, but I'm not. This patient actually did quite well. Here is a longitudinal view. You have the flexor retinaculum. You're looking at the wrist, tracing the nerve as the nerve dives down below the flexor retinaculum. So I'm a little bit more distal here at the actual carpal tunnel. And you can see the thickening here. Okay, and this is my carpal tunnel, so I maybe should be careful here. And the tendons are moving underneath the nerve as I'm wiggling my fingers. The nerve is pretty much stable, and we're turning the probe 90 degrees to visualize a cross-section of the nerve and turning it back. That's the nerve right there, and then we're turning it back. So the ulnar nerve, this arises from the medial cord of the brachial plexus. It's coded as 64450, 76942 is the ultrasound code. By the way, when you're doing these blocks, you should keep a copy of the image for billing. Ideally, you want an image in which you show the needle next to the target tissue. And unfortunately, if you're using a thin needle like I do, you may not always press save for the image at the exact time where you see it, but that's the way you're supposed to do it. So the medial cord gives rise to the ulnar nerve once again, typically C8, T1, maybe a little bit of C7, but mainly C8 and T1. This is the reason why the interscalene brachial plexus will not cover the ulnar nerve. Usually in the arm, the ulnar nerve is between the axillary artery and the axillary vein in the axilla. It can be blocked from the axilla in the mid-humeral region or by the groove of the ulnar or even distally. Cubital tunnel syndrome, patients will complain with paresthesias in the distribution of the ulnar nerve, typically the 4th and 5th digit in the ulnar aspect of the arm, may be worse with flexion of the elbow, or there may be tunnels on the cubital tunnel. And I'm sure you've done these cubital tunnel, ulnar nerve, transpositions. And the orthopedic is taking the nerve and he's moving it outside the tunnel. And when you're treating postoperative pain from this, which I see, you need to remember the ulnar nerve is not in the tunnel, or it's not where it should be. So you need to look for the ulnar nerve. And one way to do that is just trace it. You can put the probe up here above the cubital tunnel, and you can find the structure, and it looks like this. Here's the nerve. This is the tunnel. Needle entry point. Okay, so you need to be very careful not to stab this nerve. Here's my needle. You can even see the bevel of my 25 gauge needle with the ultrasound. So once again, if you're going to use a sharp needle like me, make sure you have very good control. If you are a beginner, I do not recommend using the sharp needle. So you have a bright echogenic appearance of the ulnar nerve when it's distal to the elbow. It's next to the ulnar artery in the forearm. It's surrounded by the flexor digitorum superficialis and flexor carpi ulnaris muscles. In the distal forearm, the ulnar nerve will lie adjacent to the flexor carpi ulnaris tendon. Okay, and this is what we're talking about right here. Okay, entrapment at the wrist is called Guyen's canal syndrome. Okay, here's the ulnar nerve once again at the wrist, next to the artery. Okay, so for you anesthesiologists who fell asleep for the last few slides, this one you should pay attention to. Suprascapular nerve block. I'm doing it all the time in my pain office, but as an anesthesiologist, you can supplement any sort of interscalene, supraclavicular, surgical pain with this block. It's a very easy and safe block to do. Okay, relevant anatomy here, you have supraspinatus, infraspinatus, and the trapezius muscle, which you don't see the actual muscle, but you all know it's covering these muscles in this region. The suprascapular nerve leaves the brachial plexus in the supraclavicular fossa, and it will run over the notch of the scapula, which is the traditional way of blocking this nerve, but I do not do it this way. I actually get the nerve more distal as it descends under the supraspinatus muscle and innervates that muscle, wraps around to innervate the infraspinatus muscle, and sends some branches to the shoulder joint. So looking at the ultrasound, you have the trapezius muscle, the supraspinatus muscle here, and the nerve with the transverse scapular ligament covering it. You're getting a semi-cross section. It's an oval, but not perfect cross section of the nerve as it runs by the notch and turns to go to the infraspinatus as well as to the shoulder joint. Okay, so typically it's some oval pattern right here, and there is an artery here, so be careful. The innervation of the supraclavicular nerve. Well, the supraclavicular nerve comes from C5 and C6. It is responsible for abduction, usually above 90 degrees, because it innervates supraspinatus, infraspinatus, essential portions of the capsule and ligaments in the shoulder, about 80%, but it does not supply any skin, so you should not get skin anesthesia with this nerve block. Okay, once again, this is the position that we're taking. And I'm using a high-frequency ultrasound probe here to do a nerve block, 25 gauge 3.5-inch needle, getting down to the region, going through the transverse scapular ligament, and I'm depositing a mixture of local anesthetic and steroid. Now here I'm using, it's a 10 ml drawn up. This is probably for just one shoulder. I'm doing the other shoulder on this patient afterwards. It's a mixture of 10 to 20 milligrams of depomedrol. Use dexamethasone, or there are even studies showing that you can use just local alone and get long-term relief, which is what I'm doing with my brittle diabetics or patients who've had enough steroids. And it's working extremely well. When you do this block more in the patients, their arm may be weak afterwards. The other thing I've noticed with this block, patients will sometimes report, oh, my hand is feeling warm and numb, or my radicular pain in my arm has gotten better. Why is this? C5 and C6 become the suprascapular nerve, and they do not run to the hand or to the lower arm. I believe this is happening for one of two reasons. Either the local is tracking around to the axillary brachial plexus, which is probably the more likely reason, or maybe there's some sort of referral pattern, just like you get referred pain, maybe there's some sort of referral pattern or relief of the pain more centrally. I'm not sure, to be honest. Okay, once again, supraspinatus is tapering out to a tendon here, and you have the suprascapular nerve in that region. The CPT code is 64418-76942. The most common codes I use it for are shoulder pain in the pain office. So if a patient has pain in their shoulder, you could legitimately say shoulder pain, even if it's from something else, a referred pain, for instance. And on the patients who have a cervical radiculopathy and they say, oh, yeah, I have pain right here, and they're pointing to supraspinatus, many of them will get relief with this, and they will not need the cervical epidural. Additionally, if you're an anesthesiologist, feel free to use this block in the hospital for postoperative, perioperative pain control. Here's where I inject the bupivacaine with either depomedrol or dexamethasone. And I use the 25 gauge 3.5-inch needle, but like I said, if you're a beginner, use a blunt needle. So I have another question here. Do I ever incorporate the distal branch of the axillary nerve at the humeral head or allow pectoral nerve at the coracoid for the shoulder pain? Yes, I do. And I'm getting to the axillary nerve block right now. But I've done RFA of the shoulder. I'm still working on my technique. I haven't had the best results yet, but I think it's been a long time since I've done it. And since I've done it, it was probably over a year ago. The last time I did it didn't really work too well. I've been doing a lot of axillary nerve blocks for neuromodulation, and I've gotten really good at them. So I will try again. I just haven't had the chance to try again. Thank you, Trevor, for that question. So this is just evidence to show the suprascapular nerve block is safe and effective. They're using it for hemiplegic shoulder pain. They're using it for frozen shoulder. I've seen wonders with frozen shoulder. Suprascapular nerve block, go to physical therapy or get manipulated under anesthesia, and it works really well. For non-specific shoulder pain, rotator cuff tears. I think I've avoided rotator cuff surgeries for many of my patients with this nerve block. Or post-operative surgical pain. When the joint, when the orthopedic sends the patient, they've already been through the subacromial shoulder injection, the glenohumeral shoulder injection. So there's really, a lot that we can offer the patients that they were not yet offered. Okay, the axillary nerve block. So you have here the anatomy once again: supraspinatus, infraspinatus, teres minor, teres major, the axillary nerve. This is the quadrangular space, very important space. You have this teres minor muscle, which is superior. Inferior, you have teres major muscle. Medially, you have the long head of the triceps, and laterally, you have the humeral shaft. Axillary nerve goes motor, the long head of the triceps, teres minor, and deltoid muscles. So you get the full abduction with the axillary nerve, or at least up to the supraspinatus takes over. Sensory, you get the shoulder joint as well as skin on the inferior region of the deltoid muscle. They call it the regimental badge, right? Where a soldier would have some sort of patch, I suppose. And that's the superior lateral cutaneous nerve branch of the axillary nerve. Here's a picture of the quadrangular space. Again, there's actually a syndrome, which I found. I've probably seen in the pain office, but did not recognize it until I started to teach and learn about these things. It's a rare disorder characterized by the axillary nerve and posterior humeral circumflex artery compression within the quadrilateral space. The impingement is usually due to trauma, fibrosis, bands, or hypertrophy of one of the muscular borders. There's diffuse pain around the shoulder, paresthesias in a non-dermatomal distribution, point tenderness above the quadrilateral space, or quadrangular space, depends on who you talk to. Positive angiogram findings and provocative positioning. And it may be attributed to overhead activities such as baseball, volleyball, but patients have also had cysts, lipomas, hematomas causing the compression in the space as well. So once again, humerus, axillary nerve, and here's a position of my ultrasound. The nerve is actually coming at you and then branching different ways. This is posterior, okay? And here's a little video. So once again, the quadrangular space are the muscles. The lateral side is the triceps, is the humerus, and the medial side is the long head of the triceps, inferior of teres major. Here's your humeral head. I'm going to scan more medially and find teres minor. That's the muscle on top. That's the nerve with the blood vessels around it, and I'm scanning once again the space. You see the relationship between the teres major below, minor above, and the nerve is in between them. Okay, here you have the posterior circumflex artery, the humeral circumflex artery. Okay, at this point, we're going to take a break. Let's reconvene at 11:10. And I just want to know if there's any questions before I take the break. Just of note, the axillary and the suprascapular nerve blocks have been paramount in treating shoulder pain, refractory shoulder pain with peripheral neuromodulation. In the future, I will be giving a course on peripheral neuromodulation. So thank you. And if there's no questions, I'm going to stop my screen share for a bit, and I'll see you in about 10 minutes or so. Okay, welcome back. And what I'm going to do is I'm going to actually answer a question first about frozen shoulder. We have a question asking how much local anesthetic and steroid I use. Do I ever use PRP, alpha 2 macroglobulin, um, for this block under ultrasound guidance? Okay, so I actually went over some of this in an ASIP talk I just did last month on regenerative medicine for the upper extremity. The frozen shoulder, I typically, if I'm doing a suprascapular, the question is SSMB, I assume you mean suprascapular nerve block. If I'm doing that, I use really just 5 mLs of 0.25% bupivacaine. I may add steroid if I feel like there's an inflammatory component or if I want to last a little longer. Once again, you could use lidocaine 2% or 1%. It depends on how long you want the block for. Average, it'll be 0.25% bupivacaine, 5 mLs. And the other question is about PRP, alpha 2 macroglobulin. I don't use PRP for the nerve block. Usually, I'll just use local. I'll use PRP for. You could put PRP on nerves. I mean, with epidurals, people are doing PRP. I just haven't done it for a suprascapular nerve. If I felt the nerve was inflamed, I'd consider it, but I haven't done it. Alpha 2 macroglobulin, I have not used yet. That is something that actually has been shown to help reduce deterioration of the joint with local anesthetic, with arthritis, osteoarthritis. The nerve blocks for cervical dystonia, other than Botox, I would do for cervical, aside from just Botox or trigger point injections of local, I would probably recommend cervical medial branch nerves, which we will get into later, as well as it's usually just cervical medial branch, I'd say. And the last question, for frozen shoulder, no PRP, someone's asking. I would use PRP in any inflammatory condition, pretty much. You could use PRP. Have I used PRP? I've done plenty of shoulder PRP. For frozen shoulder, though, my first go-to block would probably be the suprascapular with local. Because if it's something that can be just treated with physical therapy, you may not need the PRP. But if it's a chronic inflammation, PRP probably would help, even if it's regular frozen shoulder. I mean, it's adhesive capsulitis. PRP reduces inflammation as well as promotes with healing factors. So I haven't used PRP for frozen shoulder, but I've done it for many other shoulder pathologies, and I just don't have that experience at this time. Okay, so moving on to the lower extremity, and here we have the lumbar plexus, the 3 main terminal branches of the lumbar plexus: the femoral nerve, obturator nerve, the lateral femoral cutaneous nerve. Out of all of them, the femoral nerve is the largest. Its origin is from L2 to L4. The obturator nerve is L2, 3, and 4, and the lateral femoral cutaneous nerve is L2 and 3. So the pain management world and the regional anesthesia world have a couple different indications for femoral nerve block. In the regional anesthesia, of course, any surgery of the anterior thigh, the knee, or amputations, anything in the femoral nerve distribution, which would basically be anterior upper thigh to the medial lower leg. In the pain world, well, it's a similar territory. However, we're using the femoral nerve for peripheral stimulation as well as diagnostic nerve blocks. I've seen femoral neuralgia in my practice from patients who've had cardiac catheterizations when the femoral nerve was stabbed and they presented with a irritated, inflamed femoral nerve. And of course, the branches of the femoral nerve, such as the saphenous, can be very useful for knee pain. So the femoral nerve lies deep to the iliopectineal arch and overlying the groove between the iliacus and the psoas muscle. It's found. There are 2 layers of fascia beneath the skin. The superficially, you have the fascia lata, and more deeper, you have the iliacus fascia. So nerve, artery, vein. Here it's reversed. The nerve is on the right, then there's the artery and the vein. And you can see the ultrasound, how it is positioned over the blood vessels and the nerve. There are no muscles overlying the femoral nerve at its position at the top of the thigh. The nerve sends branches laterally soon after passing under the inguinal ligament. The first branch usually innervates the sartorius muscle. Performing a femoral nerve block, the CPT code is 64447-76942. Once again, here is the artery, vein, and the nerve. The nerve is most lateral. When you're looking for the femoral nerve, you want to find the femoral artery and vein. The nerve is typically round, oval-like, it's echo-dense in structure when viewed transversely with the ultrasound. It may contain some fascicles, which you can see as bright dots inside the nerve, or darker dots in this case. Okay, that's the nerve highlighted right there on the right. The fascia iliaca block. This is a block we used to do blind. You're going to get part of the femoral nerve over the iliacus muscle. The landmarks are the anterior superior iliac spine and the pubic tubercle. You divide into 3 parts, and then you're basically sticking a needle at the junction of the lateral 1/3 and 2/3. If you're doing it blind, you use a blunt needle. You're going down until you have 2 pops. After the second pop, that's the fascia iliaca. Negative aspiration, inject your local. Once again, this is just describing the blind technique again. We did a multi-center study a few years ago where the ED was taking patients who had hip fractures and anesthetizing them with a fascia iliaca block in the ER, followed by the anesthesia team would place a femoral catheter, and we would follow these patients. And the post-procedure pain was reduced in all the patients. It wasn't completely abolished. There were no complications, and we were able to reduce the morphine these patients took. Another branch of the femoral nerve is the saphenous, and this will innervate the knee, medial aspect of the knee, lower leg. When doing a saphenous nerve block, you need to find the nerves. You can trace the femoral nerve down through the adductor canal, and then watch as the nerve courses medially, emerging beneath the sartorius, distal to the upper leg, and in the distal upper leg, and runs subcutaneously past the knee, gives off the infrapatellar branch that continues distally, splitting off the mediocutaneous nerve of the leg. So the femoral nerve is depicted here. You can see the artery next to it. Sometimes you'll see the vein next to it. It usually lies under the sartorius muscle and between the sartorius and vastus medialis. It follows the path of the greater saphenous vein and is a sensory nerve, which it's unique because it's a large nerve, and most large nerves are not purely sensory. However, this is like the cervical plexus. You want to move, years ago, before there were genicular nerve blocks, which we'll talk about soon, I've had patients who've came to my practice failing all sorts of knee interventions, steroid, viscosupplement, surgery, or they didn't want surgery. And being an anesthesiologist, a regional anesthesiologist, knowing the saphenous nerve does provide some innervation to the knee through the infrapatellar branch, I would do saphenous nerve blocks at the distal thigh, right where this probe is. Lo and behold, with using a local anesthetic and maybe 20 milligrams depomedrol at the time, this was about 10 years ago maybe, I was able to get 4 months or so of pain relief for many of my patients by doing this. Once again, here's another picture of the saphenous nerve next to the artery. It's hyperechoic. And the depth varies depending on the patient, maybe 2 to 4 centimeters. You might need to scan for a while to adequately visualize the nerve in the location that you want to see it. Here, the needle is coming down the perineural space, depositing local anesthetic, which appears black above the nerve. The femur's at the bottom. Remember, for those of you who are new to the ultrasound, there's a hyperechoic shadow over hyperechoic bone over hypoechoic bone shadow for the bones. Okay, the sacral plexus. So originates from the L4 to S3 nerve roots and is located just lateral to the sacrum. It gives rise to 5 distal nerves: the superior gluteal, an inferior gluteal nerve, the pudendal nerve, the posterior femoral nerve, and the sciatic nerve. Sciatic nerve originates from the lumbosacral plexus and enters the gluteal region through the radiosciatic foramen between the two planes. The anterior muscle plane is formed by the obturator internus and the inferior gemellus muscles, and posteriorly you have the more superficial muscles, the gluteus maximus. And here's a picture of the nerve. After it leaves the spine, you have the piriformis muscle, which is right above it. And as you know, the piriformis can be a source of entrapment. As the nerve runs under it, through it, or above it, it really varies on the patients. So when performing a sciatic nerve block, I have the patients positioned as such, where their hip and their knee is flexed, they're in the decubitus position. And us pain doctors have the luxury of being able to get in the general vicinity of the nerve and get some relief. Whereas the anesthesiologist, if you're doing a sciatic nerve block, you really need to do a good job of getting that local around the nerve to get a dense block, or the surgeon's going to start and the patient is going to complain. When it comes to the pain office, sometimes it's not even the nerve, it's the piriformis muscle that is acting out. So if you're in the perineural space or in the piriformis, you're going to probably get relief one way or another. So it's a little tougher on the anesthesiologist, I think. Lower down the subgluteal region, you may be able to find the nerve a little easier, and then you can trace the nerve up. It's usually within 5 centimeters of the skin surface and can be blocked. So here's another image of the sciatic nerve. Here's the needle. You're getting the local and the perineural space. You could use a curved low-frequency transducer for the larger patients, maybe easier to see, or a high frequency in the skinnier patients. The big landmarks that we use are this is in the gluteal region, in the gluteal notch area, is the greater trochanter of the femur laterally and the ischial tuberosity medially. Okay, so the nerve is about 2 centimeters in width. At times it can be less than 3 centimeters below the surface of the skin. It's often hyperechoic, elliptical in shape, and surrounded with a well-defined border or aponeurosis right here. Another image of the sciatic nerve. This is in the subgluteal space, which would be right over here. Transgluteal sciatic nerve can also help quite a bit, and I do this in the office. If you're in the emergency room and a patient has sciatica, you may get some relief. I've done patients who've had sciatica from a disc herniation, but for some reason they couldn't get an epidural. Either the epidural didn't work, or they're on a blood thinner, and I've given them sciatic nerve blocks, and many of them have gotten long-term relief. And I've used in my sciatic nerve a mixture of 4 milliliters of normal saline, 4 milliliters of corpuscle bupivacaine, and steroid, either 5 to 10, 15 milligrams of depomedrol, or 2 to 4 milligrams of dexamethasone. And in every single case, the patient was able to walk out of my office, no problem. And I would drive them nuts telling them about the risk of falling after this procedure, and they don't believe me. And I have patients who do this repeat, and they tell me, you tell me every time I'm going to fall, and I never get a nerve block that I'm going to fall, but the pain gets better. So it's a nice formula or recipe that often works for patients who present with either piriformis syndrome or a sciatica, whether it's from the impinged nerve at L5S1, L4-5, or some other factor. But if they have buttock pain radiating down the leg, it will often help. Some tips. So less gain applied to the image is better than more gain when you're doing the sciatic nerve block. Try to follow the same survey pattern every time. Find the greater trochanter, the ischial tuberosity, the bone shadows, and then slide between to get to find the nerve. If you can't find it immediately, you find the subgluteal space and trace upwards. Lower the frequency, and remember the focus points. And some of the machines, they have these focus points. Typically, I use 2 focus points, and you get it to the depth, which may be 4 centimeters in this case, or where you want to find the nerve. Okay, always remember to focus your attention more medially than laterally, because you can find the ischial tuberosity when you do that. Make sure the depth of your scan is deep enough to cover the targets, and make sure your focus points are at the proper depth of where you estimate this to be. If possible, try repositioning the patient's leg to get a more flexed position, as it may help. You can also try making other adjustments, the gray maps, the enhancements, the filters, the gain, the frequency. There's a ton you could do depending on the machine you have. And if all else fails, just reset the control patterns. I'm spending more time on this because sciatic nerve is a nerve that many people do have problems finding. So here's the trick to finding the sciatic nerve. We're talking here about finding the bony landmarks. We talk about the ischial tuberosity. Here we're talking about the greater trochanter, which, by the way, just happens to be another spot that us pain doctors like to inject. So this is what the greater trochanter looks like under ultrasound. This looks like it. If it's in this orientation, this may be tensor fasciae lata going above the trochanter to insert, or it could be another muscle. Lots of muscles insert on the greater trochanter, such as gluteus medius. And you're going to find the trochanter, find the ischial tuberosity. Both of them look like bones, right? Hyperechoic with a hypoechoic shadow behind. And you're going to slide between them. And you're going to find the location of the nerve, which runs right between them. Once again, the injectate could be depomedrol or dexamethasone. I like to use my 25 gauge 3.5-inch spinal needle. When I was in training, I hung out with a pain doctor who was known as the muscle man in Manhattan. He would do tons of trigger points. That was his thing. And I remember him using a spinal needle to do trigger points in the gluteal region, and he did them blind. And every now and then he'd stab the sciatic nerve and the patient would get paresthesia. Now, once the patients get injured from this, and I'm not saying go ahead and do that. We're using an ultrasound. We're finding the perineural space. We're not sticking into the nerve. We're going around the nerve. However, if you're a beginner, once again, use a blunt needle, Stimiplex, one of these blunt needles, and it could be any brand. I'm just mentioning that because that's what I used when I was in training, but now I use a 25 gauge 3.5-inch needle. Okay, so, and you can use Kenalog. Everything I'm saying here, I have no financial relationship with depomedrol, with the Stimiplex people. This is just what I use in my practice, not to promote them. Okay, so here's the view of the sciatic nerve. You can see it's well defined right here, right? There's my needle going into the perineural space and injecting. The black is the local anesthetic. The piriformis is the muscle, either just above or in the plane that you're looking. Is it possible to not see the piriformis at all? Yes, it depends where you find the nerve. It may be too distal, especially in the subgluteal region. Popliteal sciatic nerve block. Okay, believe it or not, I'm doing these in the pain office. There are a few reasons. The sciatic nerve splits between 8 to 10 centimeters above the popliteal space. The medial portion receives innervation from the medial portion of the lower leg is saphenous, right, from the femoral nerve. The lateral, posterior, anterior is basically sciatic. The peroneal nerve is the more lateral branch. If you're looking to anesthetize the whole lower extremity, make sure you get both femoral branches, saphenous, as well as sciatic branches, tibial and peroneal. So indications, any sort of lower leg, medial, foot excluding pain or surgical area. I do see peroneal neuralgia in my office. I do see sciatica, where the sciatica starts in the popliteal fossa for some reason. I've seen it in various cases. Any sort of neuralgia, patients who have foot pain. Oftentimes I have patients who maybe are going for some sort of procedure and they need to be anesthetized at the foot. For instance, I'm doing a PRP injection or some other biologic injection, more distal, and I want to anesthetize the region. In addition, peripheral nerve stimulation, if you want to do a diagnostic block to see if the nerve is covering the spot that they're complaining of their pain in. I have another question here. I'm just going to pivot to answer. The question is long-term relief from the steroid component? Robert, what in regards to which shot are we talking about? If it's a general question, yes and no. Some patients will get relief without steroids, so I can't attribute long-term relief to steroids. Steroids basically just reduce inflammation and will prolong effect of nerve blocks in general, prolong the duration of pain relief from a nerve block. If you gave me the choice out of all of sciatica, he's an emergency room doctor, and he's doing this he's not sure if it's worth doing. Okay, first of all, if you're an ER doctor, if you're the sciatica, I consider a higher level shot. I'm not saying don't do it. I'm saying make sure you're properly trained. If a patient with lumbar radiculopathy presenting a sciatica comes to the emergency room, now this is just my opinion. I'm not aware of any sort of study or evidence base to support ER doctors, particularly with this. Unlike with the hips, there is evidence to support ER doctors doing the fascia iliaca blocks, in some cases, femoral nerve blocks. However, if you're an ER doctor, patient comes to the ER, and you're considering admitting a patient over sciatica, especially in this day and age where there's a coronavirus pandemic, and you don't want that patient who's at high risk anyway, because maybe they're elderly, to be in the hospital. And it's also probably cost effective. If you do a sciatic nerve block in the emergency room and you give dexamethasone 4 milligrams, 4 mLs normal saline, 4 mLs quarter percent pivocaine, and if you do it right, there is a very good chance you will alleviate the symptoms, possibly temporarily or for the long term. I've seen sciatic nerve blocks last months. I've seen them be curative. I've seen them last an hour. So there's a huge variety, but if you're in the ER, you'll get that patient out and refer them to a pain doctor who will then take over. That would be the best thing. If my relative was coming to the ER in this day and age, I would not want them admitted for something that can be targeted in the ER by someone good, someone with good hands, and they can go on their way. And your hospital may not be happy about losing the admission, but it is a billable procedure. So your department will probably be compensated for it. I hope that helps. Okay, so popliteal fossa, high frequency probe, sciatic nerve block, hyperechoic. You could trace down and find the nerves. They're posterior to the femur, lateral to the popliteal artery, and deep or anterior to the semitendinosus, semimembranosus muscles medially, and the biceps femoris laterally. More distally, the peroneal nerve may be followed as far laterally as the fibular head or even down to the ankle. Okay, so just pointing out the semitendinosus, semimembranosus muscles, biceps femoris. This is what they look like. The tibial nerve is larger. It's going to be closer to the common peroneal nerve when they just split off, and I have a video showing you that. And they're pretty well, here they're surrounded by local anesthetic. They're often easier to see after you inject local anesthetic. Okay, tracing the sciatic nerve down. The sciatic nerve right here is deep to the muscle. And my probe is just going down, sliding. You'll see the muscle, the nerve become superficial and bifurcate. See, two separate nerves are formed. Here is the tibial. Oops, sorry. Let's do that again. Tibial nerve and common peroneal nerve. When it stops shaking, you'll see it. There we go. Okay? The hyperlucent white tissue is the nerve. Popliteal nerve block precautions. Local anesthetic solution appears as hypoechoic, and it will surround both branches. It does take a long time for this block to work. If you're an anesthesiologist, you know that, right? You've given this block, surgeon wants to start, and it takes maybe sometimes 45 minutes. I don't know why. It also lasts longer. So there's a big, you have to be very careful with falls. Warn the patient, especially if you're doing this in the pain office. You tell them they may leave half hour after being observed, but an hour later, they could still be very weak or numb, or they could be weaker and more numb than when they left the office. So be very careful with that. Of course, I will dilute my local anesthetic when I'm doing an outpatient procedure in which I expect the patient to go home and ambulate. I always make sure the patient cannot drive, has someone to drive them home, has an escort, and understands they cannot ambulate independently until they have full neurological recovery, until they feel completely normal, sensation is normal, as well as strength. Okay, this is one of my favorites, the genicular nerves. I'm not sure if you guys caught my latest video I posted a couple weeks ago on my YouTube channel or on the pain exam website. The genicular nerve is just like the suprascapular nerve, peripheral neuromodulation, and the biologics, PRP. These are all big game changers for my practice, because once I learned about this, maybe 5-6 years ago, I stopped doing the saphenous nerve blocks for knee pain because this was working a lot better. And the superior medial genicular nerve, some sources will say it comes from the tibial and common peroneal nerve. Others will say it's from the femoral nerve, actually from vastus medialis branch off the femoral nerve. The superior lateral genicular nerve is from the common peroneal nerve or sciatic nerve, and gives rise to the superior lateral and the inferior branches. Whereas another source will say it's from vastus lateralis, which is from the femoral nerve. The inferior medial genicular nerve is from the tibial nerve, but then there are other sources saying that is derived from the infrapatellar branch of the saphenous nerve, and it runs in close proximity to the inferior medial genicular artery in the junction between the tibial condyle and shaft, or the tibial nerve itself. So the bottom line is, you don't need to get crazy with all that. You need to understand where to find them with either X-ray if you're a pain doc, or ultrasound if you're a pain doc, or an anesthesiologist. My partner, Dr. Gary Schwartz, as some of you know, he does a lot of these orthopedic surgeries still. I don't give as much anesthesia in the hospital as I used to. And he's doing this for certain knee surgeries, and he's having patients, so this combined with an IPAC block, the patients are ambulating right after surgery for knee replacements. Okay, and some of them are going home that day, something unheard of a few years ago. So landmarks: superior medial genicular nerve, inferior medial genicular nerve, and the superior lateral genicular nerve. These are the three nerves we target, but there are more genicular nerves. And the CPT code is 64454. If you get all three nerves. If you do not get all three, then modify with a 52. I'm not going to focus too much on the middle genicular nerve. It's a branch of the nervus intermedius and gives sensory innervation to the superior aspect of the knee joint. It can be blocked. The lateral retinacular nerve is from the common peroneal nerve, supplies the lateral aspect of the knee joint, and the inferior medial genicular nerve. The inferior lateral genicular nerve is not targeted because you get a foot drop, so you do not want to RF this or do anything to it. Here's my references. Okay, so once again, the big question mark because of the origin, but in terms of the lateral view, this is the idea. I know it's an ultrasound course, but I want you to understand the anatomy with the fluoroscope, because this is how most of us pain doctors learn how to do these blocks. And now the ultrasound is what I think the preferred way. The nerves will run with the artery. They usually come from posterior to anterior to innervate the joint. And with a fluoroscope, you're coming straight down. Even with an ultrasound, you could come straight down on the knee. And the targets are between the femoral or tibial shaft and epicondyle, that junction. However, as you see where the diamonds are, that's a more recent study in ASRA showing that you can get better results by targeting the corner of the epicondyle, and that's where the nerve is more superficial and closer to the surface. So you're actually sticking your needle in a little deeper than the 1/2 that was originally recommended. You're going 2/3 of the way. So under ultrasound, here's a high frequency ultrasound probe. You can see how clear the nerve looks. I made a video with a lower frequency probe, okay? And you can still see it, but not as clear as this. This is a very high frequency probe. So here's the artery, and it may not be a perfect circle or a line because it's tortuous. Okay, the probe is giving you a cross section as the nerve and the artery run down towards the knee. Once again, from the other side, is the superior lateral nerve. Nerve is right there. We're going to do a genicular nerve block. There are 3 branches: the superior medial, superior lateral, and inferior medial branch. Looking for the superior medial genicular nerve, I scan the medial side of the knee, putting on color Doppler, running along with the artery, close to the epicondyle. Take off the Doppler, and one can see the nerve next to the artery. scanning distally, the nerve approaches the corner of the epicondyle with the blood vessel. As it descends to innervate the knee. No pinch, okay. Causing 1 to 2 mLs around the genicular nerve. Bupivacaine 0.25%. Now we're going to target the inferior branch of the medial genicular nerve, going below the knee joint onto the tibia, the medial aspect, looking for the blood vessel. It's a small nerve here, may be difficult to find at times. And it runs with a blood vessel and superficial to the bone. It appears that the nerve is right here. Take off my Doppler. Go pinch. Injecting another 1 to 2 mLs around the genicular nerve in the inferior medial position. The bone over here is the tibia. Now we're going to scan for the lateral branch, which also runs with a blood vessel. So I'm going to put my Doppler on as I scan for the blood vessel to help me isolate the nerve. And I like to go as distal as possible on the epicondyle as I'm scanning proximal to distal. I'm looking for the nerve and the blood vessel. Too much pressure and the blood vessel will disappear, so it's important not to press too hard. But I found the artery and the nerve is right under it. Top of the artery, and I'm going to get the needle slightly lower. Anesthetize the nerve underneath it. There we go. That's it. That's the nerve right above my needle. The arteries to the left of it. Much easier to see after the local anesthetic has been given. Okay, so that's how I do the geniculars in the office. And the geniculars, I usually use 1 or 2 mLs local anesthetic, lidocaine 2% or bupivacaine 0.5% or 0.25% for diagnostic injection. Then we'll radiofrequency or peripherally neuromodulate, not all 3 branches, but 1 or 2 branches of peripherally neuromodulate. You could radiofrequency, or you could use something like cooled RF or even Iovera, one of these cryotherapy devices. And you could also use steroid with the local anesthetic in certain cases. In those cases, I've seen with patients who come back after a knee replacement, the knee is swollen, and the swelling from the actual surgery at the knee impedes the venous flow or lymphatic drainage of the lower extremity, and that gets swollen. So I've been able to reduce inflammation and that lower extremity swelling by doing a steroid injection near the genicular nerves. And I've seen that patients who have the post-operative knee pain often will get possibly cured quicker than those with severe OA. The ones with severe OA will usually need, the second nerve block, possibly the radiofrequency ablation or neuromodulation. Additionally, I have patients who get months of relief with lidocaine 2%, no steroid. Seen it happen many times. Seen that happen with the medial branch nerve blocks as well. Here's another great procedure. The biggest problem with this procedure is, I think, the billing. They don't recognize this as a code, the IPAC block, the infiltration between the popliteal artery and the capsule of the knee. So they recommend coding this as 64999, which is an unlisted code, and in many cases means you won't get paid, not every case. So I think you need to know it because it will be at some point reimbursed, or there may be a way to get reimbursed for this code, but it's very, very important, for the anesthesiologist who's doing the knee surgery, especially knee replacements. Here's the tibial nerve right here, the popliteal artery, the needle, posterior capsule of the knee. And for the pain doctor who treats pain of the knee. So if you see a patient with posterior capsule pain, such as a Baker's cyst or something causing it, they don't respond to knee shots, this shot works really well, okay? It's posterior capsule tibial nerve. You just stick the needle from the lateral side, just don't poke the tendon, and you can get it. Of course, don't poke the artery, don't poke the nerve, but you can get excellent response. I mean, these are patients who, they've been to the ortho. The orthopedic will say, yeah, they do the gel shots, do the steroids, and the pain is still there. So when they say the back of their knee hurts, this is the go-to shot. The biggest problem is for the payers to recognize it and pay for it properly. Here I'm using 20 milligrams depomedrol. I'm diluting bupivacaine with saline. And I've never seen a motor block from this IPAC block, by the way, which it is possible because you're by the popliteal fossa. Okay, moving distally, we have the foot and ankle. So we're going to review the ankle nerves for the anesthesiologists out there who do ankle blocks, or the pain doctors who need to do nerve blocks of the foot for various reasons, neuromas, to anesthetize the foot for other procedures such as PRP. Here you have the saphenous nerve, which is anterior to the medial malleolus, running with the saphenous vein. The vein is compressible. Okay, the nerve is right next to it, very superficial, very small. Here you have the sural nerve. Remember, the saphenous nerve is medial aspect sensory, sural nerve is lateral aspect sensory. The sural nerve is here next to the small saphenous vein. You have the Achilles tendon here. This is posterior. Here's anterior peroneus brevis, the flexor hallucis longus tendon. Here's another image of the sural nerve. You have the soleus muscle, Achilles tendon. Okay, you're coming with the probe from a lateral view. The tibial nerve, very useful block. Anterior, posterior, here's a tibial nerve. So you have the probe going upwards from the tarsal tunnel to trace the nerve which runs next to the artery, right here. The posterior. You have the muscles surrounding the nerve and the artery here. Flexor digitorum longus is close to the bone. Flexor hallucis longus is over here. Here's tibialis. Posterior is off the screen, but you can see it over here. That's a tendon, and here's a nerve. It's highlighted. Deep peroneal nerve. This is the dorsal aspect of the foot above the ankle we're looking at. It runs right on the bone next to the tibialis anterior artery. Very small nerve. You see the artery, how pulsatile it is, and it doesn't really compress like a vein, unlike the saphenous vein that we saw earlier. The tendons around it are the hallucis longus, extensor digitorum longus. The superficial peroneal nerve is more superficial, that's the name, and it's above it, and you see scanning downwards. You can see the course as it runs towards the ankle and dorsal aspect of the foot. It becomes flat, comes closer to the artery and the deeper branch. Tarsal tunnel syndrome. It's peripheral neuropathy related to compression of the tibial nerve. You have the medial, lateral, plantar branches, and the calcaneal branch. Okay, this is the innervation. So when you're doing something to anesthetize the bottom of the foot, this is the nerve block you do. It can get impinged at the tarsal tunnel. It's like the carpal tunnel, but for the foot. Here's a calcaneal branch running distally and more posteriorly towards the calcaneus. One or any of these branches can be missed with surgical decompression because the impingement does not always occur at the flexor retinaculum, but there are one of three fibrous tunnels from which these nerves branch off to and run. When looking at the patient, for you pain docs out there, MRI will identify a space-occupying lesion. Usually the podiatrists take care of that. You can look under ultrasound for a neuroma. EMG could also help. NSAIDs, orthotics, physical therapy, injections can help. Here's the nerve at the tarsal tunnel, tibial artery above it, and the veins. Okay, so we do have, I'm going to start, we have a few more minutes. Any questions before I move on to the next topic? We're going to have lunch soon, but I'm going to just start a little bit of the next topic. No? Okay. So just give me a second. Let's see if I have any more. Okay, I'm going to tee up the next one. We'll do a little bit of this before we break for lunch. Let me just get everything set up here for you. Okay, good. So soft tissue and joint injections. Okay, so you can do a lot with the ultrasound, especially with soft tissue and joints. This is a biceps tendon view. What we're doing here is we're following the biceps up. Biceps tendonitis is a very common thing we see in the pain office. Patients will strain their biceps muscle for varieties of reasons, and the pain will typically be manifested with tenderness on the biceps with palpation, as well as any sort of strenuous activity that involves flexing the muscle. To find the biceps tendon, it's usually the long head that we're dealing with here. We're going to scan upwards on the biceps muscle, and you see the muscle starts to change. You start to see a whitish tendon structure forming in the center, and it's going towards what appears to be a groove in the humerus, which is at the bottom here. Okay. Here we are looking at the biceps long head in the bicipital groove. Overlying, we have the subscapularis fascia. Okay. And you're turning the probe 90 degrees, and you're getting the longitudinal view of the tendon, where you could not only look at it, inject it, you could also identify pathology. This is overall a healthy tendon. It's the black lines here can be misdiagnosed as a pathology. However, that's called anisotropy, where you're not getting a full white appearance due to changes in the tendon structures just because your crystals of the ultrasound are not properly aligned. Here's how I usually inject it. It's a cross-section view. I come in from the side. This is fluid. This is not local anesthetic or steroid. This is fluid around the tendon. This is the pathological tendon. There is normal synovial fluid, but this is not it. This is a patient with inflammation or effusion around the tendon. I use 25 gauge 1/2 inch needle. I will inject 3 to 4 mLs of injectate, 10 to 30 milligrams depomedrol with bupivacaine, 3 to 4 mLs. CPT code for this shot is 20551 76942. That's a tendon origin or insertion. If it was a tendon sheath, like in a trigger finger, it would be a 20550 code. Trigger points are a 20552 code. Okay, so here we have the image once again, and here is a quick video just showing what it looks like in real time, injecting the biceps tendon. Coming in from the side. Okay, the needle goes just up until the region of either the fluid or the peritendon space over here, and you would inject. It would appear black around the whole tendon. Unfortunately, I don't have the image of the full injection, but you get where the needle position is. Now, the distal tendon is less effective. Every now and then, as a pain doctor, you may need to anesthetize or inject this region. Best way is to have the patient flex their arm, and you look at the tendon as inserts on the radius. So here you have the tendon, the ultrasound's over this region, and under the ultrasound, you're seeing the muscle with the tendon going to the radius bone, radial bone. And this is what it looks like as the tendon is running down with the brachial artery. Here's pronator teres. This is called the pronator teres window because you're sticking your ultrasound right over pronator teres, which is the muscle right here. The acromioclavicular joint, something we see in the operating room, in the pain office, excuse me. Almost coffee time. Okay, so we have the acromioclavicular joint at the bottom of the screen here. Basically, it's involved with all ranges of motion except with cross-body adduction, and there can be pain when there's a problem with the AC joint, when you're reaching overhead especially. There can be pain radiating to the deltoid area with cross-body adduction. It has been noted, but this is usually caused by irritation of the underlying subacromial bursa inferiorly, not from the AC joint directly. You have to differentiate acromioclavicular joint pain from calcific tendonitis, glenohumeral arthritis, adhesive capsulitis, and rotator cuff impingement. And there are a variety of maneuvers you could do to do this. The basic way to diagnose acromioclavicular joint arthritis is touch it. Touch the acromioclavicular joint. If it's tender, that's probably your diagnosis. And pain if they're pushing forward to 90 degrees with horizontal adduction. Crossover test or straight overhead pushing, as in bench press exercise, will further stress the acromioclavicular joint. Okay, here we have the ultrasound visualizing the joint. It's a very small joint, and you can imagine it's going to be very difficult to do a joint injection coming in plane with this approach. So you may need to either come out of plane, which is fairly doable. It's a small joint, maybe half a milliliter at most, maybe a milliliter it could hold. And scanning the clavicle from medial to lateral, you'll see here's the clavicle over here to the left, and the joint will appear right here, right there. See that? When the bone disappears, that's the joint. So you could do an in-plane approach from above when you have this orientation. Trigger finger, very common problem I see in the pain office. And trigger finger is from a thickened flexor tendon in the distal palm. There's abnormal gliding and locking of the tendon within the sheath. The finger gets caught. Oftentimes the finger will be stuck in this position. And the tendon is caught at the edge of the first annular pulley. Is catching during active flexion and extension. There's a stiff, tender, palpable nodule associated with rheumatoid arthritis and gout. There's no real lab test for this. You could do a lab test to rule out the associated illnesses, such as check a hemoglobin A1C, fasting blood glucose, check rheumatoid factor. X-rays are rarely indicated and performed only if there's abnormal pathology existing. You can find loose bodies in the metacarpal phalangeal joint, osteoarthritic spurs on the metacarpal heads, avulsion, injuries of the collateral ligaments. So here you're looking at the ultrasound longitudinal view of the tendons. You have the flexor digitorum superficialis tendon above, and then below it you have the profundus, the flexor digitorum profundus tendons. You can wiggle the fingers to see them move as well. This is a carpal metacarpal joint, MCP joint. The steroid injection has classically been the first line. Once again, the code is 20550. Treatment is 76942. Less commonly performed, you have splints where they hold the joint at 10 to 15 degrees of flexion, leaving the proximal interphalangeal phalange and the distal interphalangeal joint free. Surgery is indicated if there's failure after 2 injections in some practices, and surgical release of the A1 pulley is the type of procedure that they perform. So here's a cross section of the trigger finger of the tendon right here. Around it, you see an effusion. You may see an enlarged tendon, or the tendon may not look healthy when you do this block. This is the bone shadow. These are the metacarpal bones. Here, once again, in the longitudinal view and the cross-section view, you can see the difference. You have the tendon sheath on one, cross-section on another, and the orientation of the ultrasound. I use a 25 gauge 1.5 inch needle for this. Low volume, low dose steroid and local anesthetic, 10 to 20 milligrams decamedrol, 1 to 2 mLs of bupivacaine. Total injected would be 1 to 2 ml volume. You can feel the tendon sheath get distended with injection, and you may need to use an outer plane approach because you need to avoid tendon rupture here. And if you go in plane, you may not be able to see your needle tip. It may be quite challenging to do this properly. Decrevenous tenosynovitis is another disease we see in the pain office. There's thickening of an accumulation of a mucopolysaccharide in the sheath of the abductor pollicis longus tendon and the extensor pollicis brevis tendon. The extensor retinaculum is a fibrous band attached to the radius and prevents bowstringing of the extensor tendons off the dorsum of the wrist. Patients will complain of pain near the base of the thumb, swelling near the base of the thumb, difficulty moving the thumb and wrist when grasping or pinching during activities. A sticking or a stop-and-go sensation in the thumb when moving may occur. Patients will have a positive Finkelstein sign, which is when the examiner grasps the thumb and ulnar deviates the hand sharply. If sharp pain occurs along the distal radius at the top of the region or close to the wrist, the decurvains is likely. Eichhoff's test is typically described as the examiner grasping the ulnar deviated hand when the person has their thumb held within their fist. If sharp pain occurs at the distal radius, decurvains is suspected, but this is most likely to produce a false positive. Decurvains tenosynovitis risk factors include repetitive movements, pregnancy, trauma, rheumatic disease. The differential is osteoarthritis of the first metacarpal joint, or the ganglia, Wartenberg syndrome, infectious tenosynovitis, and Wartenberg syndrome is entrapment or mononeuropathy of the superficial branch of the distal radius nerve. It presents as numbness, tingling, and weakness of the posterior aspect of the thumb. Decurvains treatment would be NSAIDs, immobilizing splint, physical therapy, occupational therapy, TENS unit, a steroid injection, and possibly surgery, as there may be risk to the radius nerve, which is sensory at this region. And there's a picture of the tendon. Once again, here's an ultrasound view of decurvains, which is known as a tenosynovitis. You have the radial artery, radial bone, the adductus pollicis longus muscle, the extensor pollicis brevis muscle. You're scanning the radial aspect of the wrist. Extensor pollicis brevis and adductor pollicis longus tendons are both involved because they share a common tendon sheath. It can be caused by overuse movements that require repetitive extension or abduction of the thumb, It's a superficial injection, so the risk is skin atrophy and hypopigmentation may also occur. Okay, welcome back. Before we continue, there was a question about the genicular nerve blocks, and the question was what I use for the genicular nerves prior to radiofrequency ablation. I treat the genicular nerves like the medial branch nerves, so when we're doing diagnostics, I do the first one with lidocaine 2%, the second one with bupivacaine, either 0.25% or 0.5%. After 2 diagnostic blocks with over 50% relief, then I'll offer the patient radiofrequency ablation. Okay, so just finishing up with deeper veins treatment. So you have the ultrasound over the tendons. Here you can see the extensor pollicis brevis. The adductor pollicis longus is not as hyperlucent, but you can see the tendon cross section here. And the needle's above them. It's injecting into the tendon sheath. Usually I give 20 milligrams of depomedrol with 2 or 3 mLs of 40% bupivacaine in this region. You could use PRP. Just be careful not to inject into the tendons, of course. Okay, of note, you do have 2 different branches of the radial nerve, as the nerve will split prior to the region where I'm injecting the deeper veins. So you may get a paresthesia. Be very careful with that. Sometimes the tendons look like the nerves or vice versa. So ask the patient to wiggle or move their thumb in this case. And you should be able to notice that the tendons are moving, the nerves are not moving as much. So I'm trying to get past the nerve here. I'm hydrodissecting. And I went into the plane above the nerve to get to the tendons. Okay, here's the knee with an ultrasound. The orientation is longitudinal onto the tibial condyle and the femur. You have the patella, excuse me, the patella tendon, and the ACL is typically a slanted line up and posterior from the tibia. Here's another tendon. This is the extensor tendon on the elbow. Reasons for lateral elbow pain could be inflammation of the extensor tendon or lateral epicondylitis, the lateral radial collateral ligament, the posterior interosseous nerve, which is a deep branch of the radial nerve, exiting the radial tunnel and pierces the supinator, where it gives motor innervation. And then this dives deep to the arcata froth. The ulnar collateral ligament is noted here. And this can be injected with local anesthetic or steroid or PRP. The ultrasound would be placed as such. And you can notice the 2 different joints, the humerus and the ulnar bone. And the space between is the joint. Tennis elbow. So that's inflammation of the extensor tendons. Cubital syndrome we discussed earlier with ulnar nerve entrapment, medial elbow pain, paresthesias of the 4th and 5th digits, weak grip strength. There's a tunnels over the cubital tunnel. And you may see an enlarged nerve under ultrasound. Once again, we discussed earlier about the ulnar nerve I'm not going to spend too much time on this, but just note here in the picture, you see the ulnar nerve going through the groove by the canal, which we talked about earlier. And that's an image of the ulnar nerve in the longitudinal view, before we saw the cross-section view. We watched this video already. The lateral epicondyle here is right, the bone shadow at the right is the epicondyle. The hyperlucent structure with striations going down to the bone is the extensor muscle tendon. And the ultrasound is oriented as such. Lateral epicondylitis is also known as tennis elbow. It's chronic symptomatic degeneration over the wrist extensor tendons involving their attachment to the lateral epicondyle of the humerus. It is called epicondylitis, but it's actually a tendinosis. It should not be called epicondylitis. It's a tendinopathy. The condition affects between 1% and 3% of the population, generally affects the middle age without gender predisposition. Extensor carpi radialis brevis is the most commonly affected muscle, but supinator and other wrist extensors, such as the extensor carpi radialis longus, extensor digitorum, extensor digiti minimi, and extensor carpi ulnaris can be involved. Any activity involving the excessive and repetitive use of these muscles, such as tennis instruments, typing, manual work, intubating. I have a lot of anesthesiologists coming to me with these problems. Smoking, obesity have also been risk factors. And here's the extensor carpi radialis brevis tendon highlighted. This is the most common one affected. Treatment. Rest, modification of activities can usually lead to symptomatic pain. Physiotherapy, NSAIDs, corticosteroid injections. Sorry about the sirens in the background. I'm in my Brooklyn office today, so forgive me. Platelet-rich plasma, percutaneous radiofrequency thermal treatment, which I have no experience with in this area, but I found in the literature, and extracorporeal shockwave therapy, which from my understanding is not reimbursed, but there is some efficacy when it comes to tendinopathies and other tendon problems. They basically generate a specific frequency of sound waves over the skin of the tendon, and it's supposed to be quite beneficial for some patients. So here you have PRP and steroids, I'd say, are the most commonly performed interventions in the pain office. PRP, I've heard, is reimbursed by some payers for epicondylitis. As far as I know, this is the only procedure that is reimbursed for pain control, and corticosteroid injections are the more common procedure performed. However, the PRP is probably better for the long term. Longer term, duration of benefit, as well as decreased need for repeat injections and probably decreased side effects when compared to steroids. Others are using low-level laser therapy to stimulate collagen production in the tendons, and acupuncture has some evidence, but long-term it's unclear. When they compared PRP versus corticosteroids, they found that local PRP was associated with a superior outcome for reducing pain and improving elbow joint function compared with local corticosteroid injection at 6 months follow-up. Medial elbow pain. So here you have an ultrasound imaging the medial elbow. You see the common flexor tendon and the ulnar collateral ligament between the two bones. Golfer's elbow is caused by pathology of the common flexor tendon from overuse as it inserts on the medial epicondyle. It typically arises in the 4th and 5th decade of life, but occurs with a much lower incidence. There's greater association with occupation than sports, usually with forceful repetitive work factors than more forceful work than repetitive work being the major contributor. Usually pronator teres and flexor carpi radialis are affected, but the medial pain condylitis can involve any and all the flexors of the pronator group. Patients will present with pain on the medial aspect of the elbow that's exacerbated by resisted forearm pronation and wrist flexion. Here's a picture of where the pathology is, and here's the tendon inserting on the medial epicondyle. When doing these injections, I'll typically have the patient have their elbow flexed and put the ultrasound here. Sometimes the ultrasound gets in your way, and you need to kind of get posterior to the probe to do an in-plane injection, and be quite careful not to inject in the tendon. If it's resistant, do not inject. Also, you have the ulnar nerve nearby, so you want to be really careful. So other reasons for medial elbow pain, ulnar collateral ligament pain, which you see in pictures, and less commonly javelin throwers. And here's an image of the ulnar collateral ligament, as well as where the ultrasound would be to image the ligament. Posterior elbow, you have the triceps tendon and the humerus. I'm basically just imaging like this. You could also do a cross-sectional view. Okay, back to the knee. We went over the slide already. Here's a knee injection. So what we're doing is we're scanning in a longitudinal view the knee joint. And to the right of the screen, you have here the femoral bone. And as you scan inferiorly, you have the tibia. The space between is a joint space. And we're going to go slightly medial to the patella. I'm going to use an out-of-plane approach in which I won't see my whole needle. However, I'm getting the landmarks of the joint to avoid encountering bone on the injection. Okay, press save the camera. No, I meant, yeah, the movie film. Pinch. As you can see, there's fluid going into the joint. You can't really see the needle so well because it's an out-of-plane approach. However, we have a nice smooth injection. I'm done. Okay, so when in that view, in that level, I'm basically using the ultrasound to avoid touching the bone when I inject, because touching the bone can be more painful for the patient. A knee shot's very easy to do in general. And here is another knee injection in which I'm doing it in plane with a transverse view. And by the way, the last probe I had a completely sterile covering on. This one I've been using a lot of the images you see. I put tegaderm on the edge of this type of probe. So it is sterile. However, the handle is not sterile. Right there? Pinch. I'm sorry. Sorry about that. Right there? Pinch. Okay. The needle is really behind here. I put this highlight here so you could see where I am better. And the local is going over here. Here's a patellar tendon. And those are the main relevant structures. Housemaid's knee, it's prepatellar bursitis. In general, when in a healthy knee, above the patella, just a thin black line is the bursa. If you see a larger black line or swelling external, superficial to this, there's an effusion. The lateral collateral ligament of the knee appears almost like that of the arm, of the elbow, right? But just larger, connecting lateral femur to the fibula. Iliotibial band is lateral knee pain or lateral thigh pain. Usually it's very tender, 1 to 2 centimeters above the lateral knee, worse with running downhill and activity. There's lateral synovial recess inflammation from the iliotibial band rubbing against the epicondyle. This is seen in limb length discrepancies, genovarums, overpronation, hip adductor weakness, myofascial restrictions. And here I'm just running the probe along the iliotibial band. up and down. The band is superficial, and it divides as you get lower, so there are deeper fibers closer to the knee, and then running back up the knee. Oftentimes, you're just injecting the white band above and below with a little bit of steroid and local anesthetic. It can be confused with a lot of other problems, such as radiculopathy, neuralgia paresthetica, knee pain, great trochanteric bursitis. There is typically a signal abnormality on MRI interposed between the fatty, within the fatty soft tissues interposed between the iliotibial band and the lateral femoral condyle. And there's low signal on T1 and high on T2 weighted sequence imaging in keeping with edema and fluid. Treatments, physical therapy, anti-inflammatories. Often I'll give the patients either a lidocaine or a diclofenac gel or cream. Steroid injection, I suppose you could use PRP as well. Surgery. Differentials also include lateral meniscus tear, lateral collateral injury. So for the hip, the preferred approach in my practice is with ultrasound because it's superficial anteriorly, and you avoid the femoral artery, vein, and nerve because you can see them all, and I think it's less painful. If you're going with X-ray, then I prefer to use the C-arm because it's a little deeper. This is the orientation of the probe. It could be more parallel to the neck or as such. As long as you see the joint properly, it doesn't really make much of a difference. Keep in mind you have the psoas and the iliacus muscle and their respective tendons going over the femoral head. Here you have the iliacus muscle body over the femoral head, but the tendon is also there. So keep that in mind when you're looking at the ultrasound image. For instance, here's the iliopsoas tendon. This is the iliacus muscle above it, femoral nerve artery. Here's lateral, here's the femoral bone. Here's the hip injection. Using a 25 gauge 3.5-inch needle. We're aiming for the part of the joint where you're at the femoral head and the neck where the capsule starts. You're not going to get into that empty space you see on an X-ray because there's bone covering it. That's the iliopsoas muscle or iliacus muscle, femoral head, iliopsoas tendon. The labrum is off to the right of the screen. The needle is now resting on the femoral head, and I'm injecting. Usually 20 to 40 milligrams of depomedrol methylprednisolone with 0.25% bupivacaine, 3 or 4 mLs. You know, the shots work better for mild arthritis or moderate. If someone is severe or bone on bone, then they probably just need a hip replacement. The Achilles tendon, you have tendonitis, which is inflammation, tendinosis, which is chronic degeneration at a cellular level, and then you have rupture. In bursitis, you could see the trochanter here, as we saw in the previous, and you're just injecting onto it. Here's the gluteus medius tendon inserting on the trochanter. You can see the muscles tapering off and it's inserting onto the bone. Sorry to skip around. Back to the Achilles. I generally inject PRP here. I don't usually inject steroids. There's the risk of Achilles tendon rupture. It's a nice thick tendon, and you don't want to put a needle into that tendon. You just want to put it in the peritendon space and let the injectate bathe around the tendon. So here's another image of the tendon, and here's how I orient my ultrasound. Tarsal tunnel we discussed earlier, you have a compressed tibial nerve. Once again, the tibial nerve is here. Peroneal tendonitis, you can have inflamed tendons of the foot. And just as an FYI, most tendons look very much alike. It's really just knowing your anatomy, knowing where to look for them. Plantar fasciitis. Oftentimes there's pain by the heel. Palpation can cause severe pain. It's the most common cause of heel pain It's greatest amongst 40 to 50-year-olds with a 2-to-1 female to male preponderance. There's microscopic tears of the fascia. There's inflammation, fibrosis, myxoid degeneration of collagen tissue. So this is what it looks like when you're looking at the calcaneus as it ends and the fascia begins. Now, this is a video of a patient who underwent a plantar fascia injection and had a tibial nerve block prior. So this patient suffering from plantar fasciitis related to a heel spur, I'm going to give her a PRP injection, platelet-rich plasma, to reduce inflammation and promote healing. Prior to doing that, I'm going to give her a tibial nerve block to reduce the pain so that I don't need to put any local anesthetic with my PRP. I don't want anything to interfere with the activity of the PRP. So I'm going to go proximal to the tibial nerve, which innervates the medial and inferior aspect of the foot, and will hopefully give her enough anesthesia for the procedure. So to find the tibial nerve, I'm locating the medial malleolus. I visualize the nerve next to the artery. And one option is to go towards the tarsal tunnel, which is over here. You have Tom, Dick, and Harry, tibialis posterior, followed by flexor digitorum, and then flexor hallucis longus. With the tibial nerve in between them. Another option is to go more proximal for the tibial nerve and follow it up in the ankle. So, to the right of the screen, we see the Achilles tendon. We're going to give her a little vapor coolant spray for skin anesthesia. A little pinch. So as you see, here's my needle. It's surrounding the nerve. The black around the needle is the local anesthetic. Now we're going to image the plantar fascia. I put my probe underneath the calcaneus. The fat pad is the most superficial, followed by the beginning of the plantar fascia. As I scan distally, you see the fascia. I'm going to turn my probe transverse. And my point is anterior to the calcaneus. That's where I enter my needle, aiming towards the center of her foot. The plantar fascia is this layer right here. So now I'm going to insert the PRP, aiming for the plantar fascia. Little pinch, Regina.
Okay.
Feel that?
Very little.
Good. And you can see my needle entering into the fascia. I'm depositing the PRP superior to the fascia, as well as into the fascia. If there's resistance, I'm not injecting. And you may be a little sore here after, but it's going really well. Nice and smooth. This is the way it should feel. So basically, this patient underwent a tibial nerve block prior to the PRP injection. The PRP was injected into the plantar fascia, which can be a painful shot. The tibial nerve block alleviated the symptoms or the pain of the injection. The PRP is now on the plantar fascia. It may take a few days to weeks to work, but will hopefully give her pain relief superior to that of steroids. So that was something that I would typically do in my office to treat the soft tissue with PRP, and I used my local or my nerve block techniques to actually reduce pain of injection. This patient's doing great right now. This is about 4 months after she had that PRP shot. It was sore for a week. By the way, the tibial nerve block lasted almost a day. She had just from some bupivacaine. She was numb for a long time. And what else can I tell you? She's also had sacroiliac joint PRP, PRP in the facet joints of her lumbar spine, as well as some cervical facet PRP, and she's doing fantastic. I'm just trying to open up my next presentation. So just give me a moment here. Just have a little technical issue with my mouse. Okay, sorry about the delay. This should be good. Okay, so peripheral nerve blocks. Let's start with the genitofemoral nerve. It arises from the lumbar plexus, supplies the sensation to the skin of the anterior scroll area in males, the mons pubis in females, and the upper segment of the anterior thigh in both males and females. Here's the ductus deferens, the testicular artery. Spermatic cord is this whole honeycomb-shaped region here, pubic tubercle here. And the actual genitofemoral nerve is sometimes hard to identify. While distinct from the femoral nerve, this genitofemoral nerve originates from the upper lumbar segments of L1 to L2, and it runs as such. It descends inferiorly piercing through the psoas major muscle before emerging onto its anterior surface, and the nerve traverses the retroperitoneum, descending over the anterior surface of the psoas muscle. I typically block this nerve when I'm treating a patient who's had a hernia repair and has persisting pain radiating to the testicle. And it's either the genitofemoral nerve, the genital branch of that nerve, or it's the ilioinguinal nerve that's entrapped. And I usually will just do process of elimination, usually by a physical exam. You could tell by their complaint, by where the tenderness is, but sometimes you can't, and you need to do a diagnostic nerve block. So here's an image of the nerve. Okay, it's just a hyperlucent structure. I judge as being 1 o'clock of that artery right there. And finding the artery Doppler is a smart thing in this region because there's a lot of structures that can mimic the look like the artery, and you need to distinguish between the artery and the ductus deferens or the vas deferens. The nerve continues inferiorly, ultimately separating into the femoral and general branches. The genitofemoral nerve reaches the groin, enters the deep inguinal ring, coursing through the inguinal canal. And here's a picture of a nerve block. I'm just getting the 25 gauge, 3.5 inch, 1.5 inch needle into the region around the genitofemoral nerve. And that's my approach, from lateral to medial. Neuralgia paresthetica is a lateral femoral cutaneous mononeuropathy. If it can be misdiagnosed, there's a lot of mimickers. It can be misdiagnosed as hip pain, radiculopathy, greater trochanteric bursitis. Typically, there's dysesthesia or anesthesia in the distribution of the lateral femoral cutaneous nerve. Patients will report burning, coldness, lightning-like pain, deep muscle achiness, tingling, anesthesia, or hair loss in the anterior lateral thigh. It can go on untreated for years. Often you'll see this in patients who wear tight belts or they are obese. It's primarily a sensory nerve, but also has some efferent sympathetic fibers with vasomotor, pilomotor, and supramotor impulses. Its origin is variable. L2 and L3 is most common, L1 and L2 sometimes, L2 alone, L3 alone at times. It's associated with the femoral nerve as it passes through the inguinal ligament, or may anastomose with the femoral nerve distal to the ilioinguinal ligament. Occasionally, it's absent and may be replaced by a branch of the ilioinguinal nerve, and it's frequently found passing through the split lateral attachment of the iliac ligament. As the nerve curves medially and inferiorly around the anterior superior iliac spine, it may be subject to repetitive trauma, as this is a fiber osseous tunnel. It provides cutaneous innervation of the lateral thigh, once again, L2 and L3, goes under the inguinal ligament, in case you missed that last time. It's 2 centimeters medial to the anterior superior iliac spine, and then it runs superficial to sartorius and divides below the muscle and into anterior and posterior branches. The nerve is superficial to the iliacus muscle and between the fascia iliaca and the fascia lata. Okay, so here you have the nerve when you're looking down medial to the anterior superior iliac spine. That's the iliacus muscle over there. The ASIS is on the right side of the image. It's the bone shadow that you see. That's a sartorius muscle, and you're seeing the nerve as it courses above the muscle, and the iliacus is deep to it. Once again, as a branch goes under the sartorius, you're seeing it. The peroneal nerve and the popliteal fossa. The peroneal nerve can get impinged at the fibular head. Classic anesthesia question on the boards, right? The patient is in the lithotomy position for a prolonged period of time, or gets a foot drop from trauma to the lateral knee or lower leg. Look at the peroneal nerve. Here is a cross-section of the fibula head, and look how close the peroneal nerve is to it. Once again, this is where the ultrasound is positioned to find this. The intercostal nerve block. Introduction. The block is so old. In the early 1900s, they've been blocking this nerve. They've been using local. Probably back then they used cocaine to block it, which we obviously are not using anymore. Maybe they use lidocaine. And the nerve runs under the artery. You could use a neurolytic such as alcohol or phenol, pulse radio frequency or cryotherapy. There are 12 pairs of thoracic spinal nerves, T1 through T12. They're divided into the ventral and dorsal rami as they pass through the intervertebral foramen. The ventral rami form the intercostal nerves that enter the intercostal space. The ventral ramus of T12 forms a subcostal nerve that is located inferior to the 12th rib. Here are the positions that your ultrasound will be on when you're looking at these nerves, either getting a cross-sectional view below or a longitudinal in-plane view above. T1 through T12 passes posteriorly to supply sensation to the skin, muscles, bone, and back. The nerves are composed of the dorsal horn sensory afferents, ventral horn motor efferents, and postganglionic sympathetic nerves. The major branches are anterior and lateral. CPT code for blocking this is 64420 plus 64421. You could do this under fluoroscopy or ultrasound or blind. Of course, I recommend ultrasound. And to note, the lateral branches of the nerve give fibers that run anterior and posterior. Therefore, you can do a block proximally and distally, distal block and get proximal anesthesia because the nerve wraps around of the skin I'm talking about, anesthesia of the skin. In the olden days, they used to do this block blind where you palpate the rib and then you insert the needle to contact the rib. You pull the skin down and walk off the rib 1 to 2 millimeters, aspirate and inject. Remember, the intercostal space has one of the highest vascular uptakes of any location to do a nerve block, so be very careful when you're doing this block. And you don't want to go in any more than 5 millimeters to prevent pneumothorax. Of course, it varies from patient to patient. Some patients may be 2 millimeters. So you have to be smart about how you do this. And of course, I wouldn't do it unless I didn't have an ultrasound available, but I would do this with an ultrasound. So here's an image of the nerve artery vein. And here's where you can get the, here's the lung, here's the intercostal muscles. This is the position that probe is in. Ultrasound gives high resolution, real accuracy because you could see the nerve, you could see the rib, you could see the lung, you could see the pleura moving. It's fairly cheap these days. The ultrasounds have come down in price. And of course, it's all cheaper than getting a pneumothorax, hurting a patient, getting sued, if we're going to talk dollars and cents. There's plenty of articles to support the use of an intercostal nerve block for various reasons. They've used it for post-anesthetic, for intraoperative pain relief for a nephrolithotomy at T12. They've used it for thoracotomies. They've used it for all sorts of procedures. So here's a cross-section of the rib. The pleura is here, and in real time, this is actually moving with the lung. And the intercostal muscles are here. The nerve is right here under the rib. Pneumothorax, bruising at the injection site, bleeding, of course, is a risk. Infection, nerve injury, allergy to contrast. Here's an old video, so the quality is not the same as the newer videos, but I think I get the point across. This is useful for flail chest, rib fractures. Of course, you have to do each individual rib, which has a disadvantage because it's a lot of shots. Always aspirate before you inject. And monitor the patient, give them instructions if they have shortness of breath or any signs of a pneumothorax post-procedure. But you don't need to routinely get an x-ray if you do this under ultrasound in your pain office and there's no suspicion of pneumothorax. There's more articles about lengthening hospital shortness of stay, even getting symptomatic relief with post-traumatic neuralgia, which I've seen varying responses to. I wouldn't swear by any of these blocks for post-traumatic neuralgia, but some of them do help. People are also putting intercostal nerve blocks for pulmonary procedures, thoracotomies. I see it with a lot of post-thoracotomy pain. I do this intercostal nerve block for. People are using I found a report of tetracaine for post-traumatic neuralgia. Okay, the paravertebral nerve block was a popular technique in the early 20th century. It was basically abandoned for a bit, or wasn't as popular until the 1970s when there was a renewed interest. It's basically a unilateral block of the spinal nerves that gets the dorsal and ventral rami as well as the sympathetic chain ganglia. It's commonly performed at the thoracic level for good reason. 64461, 64462 for multiple levels are the codes, and you can add ultrasound read at 76942. In the thoracic level, you can do one shot and it will spread to multiple levels because it's a continuous space, unlike the cervical or lumbar levels. Therefore, instead of doing a shot for the rib fractures at each level, you could do it at one level and get the same results with less of a risk due to multiple injections. It's used for surgical and non-surgical techniques. This paravertebral nerve block, open thoracotomies, VATS, breast surgery, minimally invasive cardiac surgery, renal surgery, open or laparoscopic cholecystectomy, appendectomy. There's also non-surgical indications, postherpetic neuralgia, post-thoracotomy, pain, fractures of the ribs, labor pain. People are using it for pain from mesothelioma. I mean, I've never done this for labor pain or mesothelioma pain, or even for hyperhidrosis. These are just indications I found in the literature. So posteriorly, you have the superior costotransverse ligament, which is a continuation of the internal intercostal muscle. Anterior laterally, you have the parietal pleura. Medially, you have the vertebral bodies, intervertebral foramina, and the intervertebral discs. The paravertebral space in the thoracic spine is wedge-shaped, running the length of the thoracic vertebral column bilaterally. Unlike the cervical and lumbar regions, like I mentioned earlier, there is continuity, allowing for the medication to spread. So here you have the approach when you're going in plane transverse view. Okay, the ultrasound is close to the spine, oriented like this on someone's back. You take an angle to avoid contacting the lung and get more or less to this corner over here where the needle tip is. Patient can be sitting on the side in the decubitus position or prone. You want to find out where the spinous process is. When I did this blind a long time ago, we would palpate the spinous process 2 finger breadths lateral, and we would insert until we hit bone the transverse process, and then walk off and go another centimeter or so. Obviously, with an ultrasound, it's a lot safer and easier. You can also do this in the fluoroscopy with contrast. However, I don't recommend it if you have an ultrasound. So in the thoracic spine, the spinous processes are corresponding to the next numbered nerve root because they're angled downwards, whereas in the lumbar, they're angled at the same level of the exiting nerve root. So why am I doing paravertebral nerve blocks in the pain office? Well, I see patients who've had spinal cord stimulator insertion pain at the thoracic level. I have patients, and they respond beautifully to this. I've had patients who have thoracic radiculopathy from a disc herniation in the thoracic level. Less common than cervical lumbar, but I see it. And in my opinion, it is safer to do an ultrasound-guided paravertebral nerve block than an epidural at this level because there's no spinal cord where I'm working. Are there arteries? Yes. You have to be very careful, and I often use dexamethasone and not a particulate steroid. Okay, so there's different positions you could keep the patient in for this procedure. When your injector, when you get into the paravertebral space, there is a loss of resistance as the needle tip penetrates the superior costotransverse ligament. You want to aspirate, and I usually inject 3 to 5 mLs of injectate. You could place a catheter here if you're dealing with inpatients for surgery, for rib fractures, for flail chest, for multiple rib fractures, or metastases to the ribs. Okay, and here's a picture with the overlap with underlying an ultrasound view. So watch carefully as the picture dissolves, and you'll see the ultrasound view. And there's the lung moving with the pleura, and the target is where the star is now. That's the pleura. Here's the needle coming in that trajectory. And you see the lamina and the spinous process here. This is a block that many pain docs are not using in their practice. And if you're considering a thoracic epidural on a patient, as long as you're competent, if you know how to do this block safely, try this first. I think it's safer. Yes, there are arteries feeding the spinal cord, and you need to be careful, but your needle is not near the spinal cord. And I've done many of these in the office. I've never seen any sort of hypotension. I'm not saying it won't happen. Have monitoring, have all your stuff there. I've been doing this for a very long time. and I'll do multiple paravertebral shots. I give a total of sometimes 10 mLs, 40% bupivacaine. If you're truly in the paravertebral space, you should not get hypotension like you would with a sympathectomy from a nerve block at the epidural space or some other sympathetic block. Speaking of which, you are getting sympathetic nerves with this. The local anesthetic is getting, you're really getting the best of all worlds here, because you're having access to the nerve root before it splits. You're getting it's almost like a transforaminal. It's not quite as deep, but it is almost. You're getting the sympathetic fibers that go on the anterolateral aspect of the sympathetic chain of the vertebral body. You're getting the nerve as it branches out into the medial branch, so even for axial symptoms, and you'll get a lot of relief. I've even been able to treat visceral pain of the pancreas by doing a paravertebral nerve block on a patient. It didn't last so long, but I was able to get a patient who was in my office with pancreatic cancer pain and needed an acute shot. I didn't feel comfortable doing celiac plexus with ultrasound in my office. So I did the paravertebral at T8 or so, and the patient had relief. It lasted like a week or so. Complications: failed block, hypotension, vascular puncture, pleural puncture, pneumothorax, and I'm sure there's other issues that can happen. This is a longitudinal view, and here I'm just showing you the orientation of my probe. I'm going longitudinal because I'm between the scapula. It's very hard to do a transverse view because the scapular bone's in your way. And I'm just inserting a needle and I'm anesthetizing the soft tissue, the rhomboids here. And you'll see that the star is actually the target. The needle tip gets just above that to the intercostal muscle region, and then the video cuts out. So I hope you get the idea of how this is. The pleura is right below this right here. So the target is to get right a little bit, maybe under the star in that region, and that should give you good spread. There's plenty of research supporting the paravertebral nerve block for a variety of indications. Postoperative pain, they're using it in pediatric pain, pediatric postoperative pain for the they're comparing it to the intercostals. They've even used it L1, L2 for patients with hip surgery, for avascular necrosis, thoracotomy, breast cancer surgery. People are neurolysing this for cancer pain. Okay, moving on to the head, occipital headaches, which we see a lot in the pain office. So pain radiating from the occiput anteriorly, secondary to compression as the nerve exits. There's fibrosis, muscle spasm, and other problems that can cause the occipital headache. It can be related to cervicogenic headache related to cervical pain, because the occipital nerves do originate from the cervical nerves, C2, C3. When you're doing the occipital nerve block, the blind approach was to palpate the occipital notch, feel the artery, give a field block of 4 mLs or so of local. Now with the ultrasound, we can use lower volumes. The anatomy that you need to know is the atlas, the axis. The C2 spinous process is bifid, meaning there's two horns, you could say, of the spinous process. The obliquus capitis inferior muscle, note right here, okay? The occipital nerve runs right over that muscle, so remember that because we're going to watch a video soon. The spinous capitis muscle is over all of that, and it runs in a different direction. And the lamina of C2 is located around this level where the obliquus capitis inferior muscle is. The greater occipital nerve is hyperechoic above this obliquus capitis inferior muscle. So here is the bifid spinous process. And here's the orientation of your ultrasound. And here's the video. We're scanning lateral now. Okay, that's the lamina, the bone at the bottom. C2. See how the probe is oriented over obliquus capitis inferior? That's a deeper level. Spinous capitis muscle is a more superficial level. And the nerve was between them. Supraorbital nerve, sometimes the ultrasound is just too big and it's hard to do this nerve block. Not a lot of room for your nerve to work. But it is nice to see the nerve, and you can do it. It's a very small nerve, very thin nerve. But with a high frequency ultrasound, you can see it. It's a branch of the trigeminal nerve, so I use the trigeminal nerve code for this one, 64400. Superficial cervical plexus block. Turn the head. You identify the superficial cervical plexus. It's at C234. The nerves originate to become this plexus. Horizontal between, you could put the ultrasound probe halfway between the mastoid process and the sternocleidomastoid at the clavicular head. The plane between the sternocleidomastoid and the scalene muscles is where you're working. The code is 64413-76942. Why am I doing a superficial cervical plexus block in the pain office? In the anesthesia world, maybe for a carotid endarterectomy, maybe for thyroid surgery. In the pain office, I see people with all sorts of problems, clavicular fracture, right? The supraclavicular branch will innervate near the clavicle. Patients who have myofascial pain due to surgery of the neck, or they have pain radiating to the mastoid, to the lesser occipital nerve, or anywhere under the jaw. Okay, this is a block I'll do just a couple times a year, but it's very useful, very safe to do. And keep it in mind for those clavicular fractures, especially if you're in the orthopedic office or in the emergency room. Okay, you want to find the sternocleidomastoid muscle, and you're just infiltrating 2 to 4 mLs of injectate right behind the muscle in this plane. Okay, it's like a plane block because it's hard to see each individual nerve, but these little white dots here are probably the nerve. It's a sensory nerve. This is a distribution of the nerve. Okay, it's a pretty large distribution, so it's actually a very useful shot. You could probably use it for cancer pain as well. The deep cervical plexus block, okay, pain docs don't really need this one. This is more for the anesthesiologist when you're doing your carotid artery surgeries. You could just stick the needle deep to the carotid artery, right where my target is over here, and you're getting the nerves as at the posterior aspect of the carotid sheath. The tap block, anesthesia of the parietal peritoneum and the abdominal wall. It's a controversial as to which levels exactly, but generally it's T7 to L1, and this is useful in acute and chronic pain settings. I took this from my anesthesia days and I applied this to my pain practice, and lo and behold, many patients come to me with abdominal pain. Unfortunately, they just stick with their gastro or the visceral pain docs to gynecologists or urologists, and they never get diagnosed properly. Or they go to the pain doctors who don't know how to use an ultrasound, see a patient with chronic pain, give them opiates. And what happens? The patients get more constipated, bear down more, and their pain gets worse because it's not really visceral. It's a myofascial pain. There's already muscle spasm strain from the surgery, appendectomies, hernia repairs, any sort of stab wounds or other injuries, laparoscopic. There could be any reason, anytime there's surgery, or even not surgery, anytime something happens, there's always a possibility that it's a myofascial muscle, connective tissue, nerve pain. It doesn't have to be a visceral pain. Okay, if it's a visceral pain, bowel, viscera, I wouldn't recommend a tap block. However, I see in my practice, visceral pain sometimes comes with somatic pain. You help one, you could help both. Of course, that varies from patient to patient. So you have the intercostal nerves from T7 to T12, the subcostal, T12, iliohypogastric at L1 is also here. You have the triangle of Pettit right here, which is made up of latissimus dorsi, external oblique, and iliac crest as the borders. The floor is the fascial extensions of the external oblique, and this is from superficial to deep. And the internal oblique, the transverse abdominis, and the peritoneum. Okay. Here we have a needle, it's very faint here, subcutaneous fat, external oblique muscle, internal oblique muscle, the transverse abdominalis plane, transverse abdominis muscle. Here you can see even in the plane, there's a little thickening, a white thickening. Those are the nerves, those are intercostal nerves. Here we take an ultrasound and we're scanning from axilla towards the anterior, okay? And you see here, the transversalis fascia starts to come into view as we move anteriorly. Now we're moving anteriorly, and you see the 3 layers of the transverse abdominis muscle, the internal oblique, and the external oblique. with the tap plane between the internal oblique and the transverse abdominis muscle. And that's the target. You see that's a little thicker here than this level. This is because there's nerves here. This thickness is a nerve. Oftentimes when you stick a blunt needle in here, or a sharp needle, usually a blunt, you get a paresthesia. And the bowel is down here, so don't touch that. Subcostally, sometimes we have patients who have pain underneath the rib, anterior lateral in that belly wall. It's maybe because they have a jejunostomy tube or a peg tube that's painful. And here is the plane that you're working in, okay? It looks like the other tap plane, but we're just under a rib. I have patients who've had peg tubes placed, and the gastroenterologist will probably injures the intercostal nerve and causes chronic pain, or the nerve becomes entrapped from the equipment that they put in. Complications of the tap: bowel perforation, take you back to internal medicine or surgery days. This is free air. I've never seen free air after a tap lock, but I figured I'd just add this slide just to refresh our memories as to what that looks like. Bowel hematoma, never seen. Femoral nerve palsy, never seen. Infection, never seen. However, I have seen patients who get the large doses of local come in with they look like the muscles become lax, or maybe because of the distension of the muscles from the fluid, and they have like a little abdominal wall laterally comes shaped outwards, but that's temporary and of no significant consequence. I'm going to move a little quicker here because we still have a lot more to go, and I don't think I'm going to take a break. So if you need to take a break, you could just watch the replay where you'll have access to everything. It's just that we have the spine to do, and we're almost there. So let's finish with this. The ilioinguinal nerve indications: lower abdominal groin pain, C-section pain, postoperative inguinal hernia, or perioperative repair. That's why I typically treat in my office. Somatic pain, ilioinguinal neuralgia for various reasons. Thank you. Here's an image of the nerves next to the blood vessel. You have the external oblique, internal oblique, and the transversalis below it. It's almost like a tap lock, but you're going in the line between the umbilicus and the anterior superior iliac spine. The Doppler will help you identify the blood vessels in this plane, and you will go through the internal and external oblique muscles to get to this plane. So here's a little video. The biggest challenge with this approach is fitting the needle between the anterior superior iliac spine and the actual ultrasound probe. So you have to sometimes take your ultrasound, angle it outwards, and get between them. And you can see here that it's pretty obvious the nerve is next to the blood vessels. You have the internal oblique muscle right there. Bowel is deep. This is a fairly easy block to do, and works quite well. I use 4 to 7 mLs of 1/4% bupivacaine with or without a steroid. If you inject much higher volumes, you can get a femoral nerve block. And the reason for that is I drew this picture hoping that it would get the point across. The medication could track down to the fascia overlying the femoral nerve, the iliacus fascia, as it travels medial and then inferior onto the femoral nerve fibers. And I've seen patients with higher volumes, like 10 mLs of local anesthetic, get a complete femoral nerve block. So in my office, I'm usually sticking to 5 or 6 mLs maximum. You can also get any sort of vascular injection, nerve injury, bowel perforation, hematoma. Okay, so we have one more lecture to go. If you need to take a quick break, now's probably a good time, but I'm not going to be delaying much. I'm just getting it teed up here. Are there any questions in the meantime? We're starting the last unit. I'm trying to finish on time. just going to take a couple minutes to load, hopefully less. So while this is loading, I'll just tell you all that the replay should be emailed to you sometime this week. I just need some time to configure it, get it together. Don't forget to claim your CME credits for this. In addition, I am going to be doing live training in person, either in one-on-one, if the pandemic is still there, or in small groups. And once, hopefully we'll all get vaccinated and everything will work, we'll go back to larger courses. So just keep the date on keep listening to the Pain Exam podcast, keep checking the website, the events page, or the Pain Exam newsletter, where I update you as to all the courses that I'm doing. Okay, it's almost there. In terms of marketing your practice, whether you're an anesthesiologist or a pain doctor, not everybody's doing these nerve blocks. Not everyone's doing it in such a way. So you can get a name in your hospital or in your region amongst the orthopedics as well as the spine surgeons. A lot of spine surgeons will appreciate if you don't go straight to the epidurals, because some of them have had to deal with the complications that epidurals can cause in the cervical and thoracic spine. A lot of the orthopedics will appreciate if you can take their post-operative disasters off their hands. And one way to do that, aside from doing the nerve blocks, is with radiofrequency ablation of the genicular nerves, possibly their hip or shoulder. There are new techniques to do that. Or peripheral neuromodulation, putting wires on these regions and stimulating the nerve. So don't worry, this will pop up in a second. Here we are. Okay. Okay, so I put the stellate ganglion in with the spine because it's close enough. So the stellate ganglion supplies a sympathetic innervation to the upper extremity, and it's through the gray rami communications of the C7, C8, T1, occasionally C5 and C6. In some patients, T2 and T3 gray communicating rami innervate the distal upper extremity and do not pass through the ganglion. Hence, they're sympathetically mediated pain, but they're not relieved with the nerve block. So you may not get relief of the pain, even though it is sympathetic. The CPT code is 64510, and you add the ultrasound code. When I was in training, we did this with fluoroscopy, which there's a lot of reasons why I advise not to do that these days. And I've even seen one of my docs who may be listening here, who was one of my former attendings, do it blind, where you palpate the carotid and you move it to the side a little bit, stick a needle between the trachea and the carotid, get to bone, pull back a few millimeters, aspirate, inject, which, as you can imagine, is not the best way to do it these days. Maybe before ultrasound it was acceptable, but these days we're doing it with the ultrasound. So the stellate ganglion can be used for neuropathic pain problems such as CRPS type 1 RSD or causalgia type 2. Some people have used it for refractory angina, phantom limb pain, zoster of the face, lower cervical, and upper thoracic dermatomes. There are reports of using it for pulmonary embolism, which I've never done, as well as all sorts of vascular or vasal occlusive syndromes such as Raynaud's, scleroderma, accidental injection of a vaso-occlusive substance into a radial artery, for example, to treat emboli of an artery, to vasodilate the extremity. But typically I'm using the stellate ganglion for post-traumatic stress disorder. It helps with the sympathetic symptoms related to it. Works pretty well, in my opinion. I have patients coming back every 3 to 4 months for repeat injections, and causalgia symptoms. And it typically will work best when given early for the RSD or CRPS-like syndrome. So complications. Well, you can see here that you have a lot of things in your way when you're sticking a needle between the trachea and the carotid artery, aside from the trachea and the carotid artery. You have a thyroid, which sticking a needle through is usually not a big deal, but there are blood vessels there, which I'll show you soon. And behind it, you also have the esophagus, which even if you're using an x-ray with contrast, by the time you get an esophagram, it will be too late. So I don't advise using x-ray. I definitely think ultrasound is the way to go. You could get vagal nerve block, brachial plexus nerve injury or block, hemothorax, chylothorax, pneumothorax, esophageal perforations I mentioned, epidural block, intrathecal block if you're really off, carotid, vertebral arteries you can get. You could really create a big mess. And in the neck, everything is so close together that you really need to be careful and understand what you're doing. So when you scan in the neck and you scan the thyroid, you'll find that the carotid gives off a branch. One of the branches of the superior thyroid artery, which is a pretty large branch of pulsatile blood that you really don't want to get involved with in the neck. Okay, Doppler is your friend. You can always check Doppler to see if you're getting if you're near a blood vessel. Here is a picture of the Horner syndrome on one of my former patients, ptosis, meiosis, anhidrosis. I mean, this is really significant Horner's right here. Okay, so how do we identify the esophagus when we're doing a stellate ganglion block? Ask the patient to swallow. You'll see it soon. So that, do it one more time. Okay, but you see the thyroid here. This is an ideal level of the neck in which to get the thyroid because you don't see any blood vessels here. Okay, here's the neck when you're looking down at it, and you could see how many blood vessels are here, how many nerves are here, how careful you need to be. The lateral approach, you take the needle to the side. You're not going from the thyroid. You're going from lateral to the ultrasound probe. You're getting behind the sternocleidomastoid, and you're coming in at an angle, and you're getting the local anesthetic posterior to the carotid. You're leaving the thyroid alone. And it seems great and perfect. However, you do need to be careful because you have the brachial plexus nerves nearby. Oftentimes when I do this block, because we're going at the level of C6 or C7, I will elevate the patient's head of the bed so gravity does some work to go downwards towards C7, as well as have the patient look upwards. And sometimes they're sedated, so they'll be asleep and the anesthesiologist will just tilt the chin back. Okay, here's the video. You see the carotid pulsations, and this is my needle over here, and I'm injecting local. This is the transverse process of the cervical spine at C6. This is the longest coli is this muscle over here. Another picture. This is the medial approach. So the needle's coming through the thyroid to get the stellate ganglion. So this isn't finding the carotid artery, and there you see the superior thyroid artery, which you want to stay away from, and the thyroid gland. Okay. So if you see yourself, you're pretty safe. You just need to see where your needle tip is and where your needle is, and that's the target. I'm behind the carotid. I'm using it for PTSD and CRPS mainly. Here's with a different ultrasound probe, a newer one. Okay. I'm transthyroid in this approach. And I'm giving the local. Sometimes with the patient breathing, it changes the screen, so you have to sometimes just get in there quickly and carefully with care not to take and not to puncture the carotid. And that's one reason why you probably don't want to do this on a patient who's anticoagulated. If they have a pneumothorax on the contralateral side, well, I don't know why you would be doing this, but don't do it. Recent MI, they say the stellate ganglion can cut off the cardiac sympathetic fibers, the accelerated nerves. You can get profound hypotension, bradycardia. Glaucoma is a relative contraindication. You could provoke it with repetitive stellate ganglion blocks, as per some reports. And patients with an AV block, there's impairment of cardiac function, and you can make it worse. Complications, pneumothorax, or axial injection. We mentioned most of these, right? Phrenic brachial plexus nerve block, hematoma, esophageal perforation. Okay, moving on to the sacroiliac joint. Okay, pretty simple with an ultrasound, actually. You find the posterior superior iliac spine. Now, at the superior aspect, you find the PSIS and the sacrum, and here's your joint. It's the space between you. You just come in from an angle like you normally do with the SI joint, and you pop into the joint, and you aspirate and inject. It's very easy to do, actually. As you slide more inferior to the inferior pole of the sacroiliac joint, as you would do under X-ray guidance, which most of us do it that way, the PSIS disappears and the bone comes right around to this level, so it's not as profound, the joint space. And I do think it is easier to get into the joint from the superior aspect with the ultrasound, unlike with the X-ray machine. Okay, here we have the lumbar facets. You're looking at an ultrasound with a superimposed drawing of the vertebral body. Here is the image, the shadow of the spinous process, the lamina hyperechoic with hypoechoic behind it, the facet joint, and the transverse process. The needle's coming in right here to the joint, and this is with a low frequency ultrasound probe. The medial branch nerve is located here. Okay, once again, the spinous process shadow, the lamina is over here. And the lumbar facet, okay, what I'm doing is I'm taking the probe over the sacrum in a longitudinal view, medial to the posterior superior iliac spine, and I'm visualizing the sacrum, and this bone here is typically the L5-S1 facet joint. If you scan laterally, this bone disappears. And medially, you'll find the epidural space, so this will disappear, and then you'll find the other facet joint on the other side. The L5 dorsal-ramus, it's not that I'm actually seeing the nerve here. I'm seeing the sacral alar, which is a landmark for the nerve. And I'm injecting it. So I go lateral to the facet joint, which you may see here is the bone, and it disappears as I go lateral, and the needle's coming here to the edge of the sacrum, and the local is going on this. So usually I'm doing this under fluoroscopy. Every now and then I'll do it under ultrasound. If I'm doing, let's say, I don't have access to the C-arm, and the patient's presenting with severe either muscle spasm of the lower back, and I want to do a nerve block to that multifidus muscle, I'll do a dorsal-ramus or medial branch block. If, let's say, I'm doing some sort of, if I just do a trigger point and I just want to get a little extra relief, I'll do that dorsal-ramus injection as well. And by the way, anterior to the L5-S1 is the superior hypogastric plexus. Here's the sympathetic chain. Here's the ganglion impar, anterior to the coccyx. Okay, so once again, spinous process, lamina. This is transverse view of the lumbar spine, transverse process. Here you have your spinous processes. Your lamina are here. And the medial branch nerve target would be right in the corner of that superior articular process and transverse process. Here's the facet opening. Okay, this is what it looks like. The gap in the bone is very small. You can't see this in everyone, especially if they have a lot of degeneration or an osteophyte, which can cover the joint opening. So now we're looking at the cervical spine. We have an atlanto-occipital joint on top. The cervical spines are labeled as you go down. It's This is an AP view. Here is a view looking down on the cervical vertebral body, which is shaped differently than a lumbar or thoracic. Very important how you look at this picture when you're considering the beautiful thing about the neck, because the neck is, in my opinion, the highest risk area of the body. It's great that you can ultrasound from any side and see vital structures because of the size of the neck. The width of the neck is so narrow compared to the torso, abdomen, pelvis. You can get on all sides, and you can do shots from the side much easier, and therefore you can see the nerves as they leave. So here, the relevant structures for sonoanatomy, I'd say, are the spinous process, the articular pillar, posterior tubercle, the foramen transversum for the vertebral arteries. Note the exiting nerve root as it comes out anteriorly, not just laterally, it's more anterior. And the medial branch nerve, which wraps around here to innervate the joint as well as the muscles. So one thing that we talked about earlier was locating the brachial plexus and then tracing them back upwards. So I'm going to show you that video again as we travel upwards and we trace the nerves of the brachial plexus up to the neck. So here's the interscaling brachial plexus, C5 and C6, right there. And to review from a few hours ago, we're going now superior and posterior with the ultrasound towards the neck to find the foramen and the nerve as it comes into the foramen. Okay, so what does that look like here? So we have the articular pillar, the cervical nerve root, and the needle coming from posterior, okay? If I don't do transforaminal cervical epidurals. Some people do. When I trained, it was frowned upon due to the risk of vasospasm embolization of the spinal cord. So what I do in my practice is a selective cervical nerve root block, extraforaminal, outside the foramen, and I could do it either using a C-arm to get my level or tracing upwards with the ultrasound. I place the C-arm, the ultrasound on the base of the neck at the level I'm shooting at, and the beam is coming as such. If you look here at the side, so you're seeing the articular pillar as it's a curved structure here, and you can see the exiting nerve root and medial branch nerve, and in this case, the vertebral artery. Okay, my needle is not coming anywhere near that artery. And just on further note, when you're doing the shot, if you get to the medial branch location where this articular pillar is, which I'll show you on the upcoming slide, or even a little bit anterior, and you see there's no blood vessel here, you can actually have the medication spread medially, and it could go towards the nerve root and into the foramen and get some anesthesia there that might be helpful for the patient. Cervical facets between the bones and the neck, they're joints. They look like a shingle under ultrasound. Okay, they have a shingle-like appearance, like a roof. Okay, and these gaps between the bones are the joints. This is how I orient my probe. I used to do a lot of these. I don't do this so much anymore. I find it to be more painful for the patient, and I've seen more vasovagal than when I do the medial branch. As a just FYI, the way I do these shots is I have the patient sitting up, hence the big issue with the vasovagal. You don't want anyone fainting. And their neck is flexed. With this approach, I found it just to be too painful. I do a lot of RFA, I do a lot of medial branch nerve blocks, and so typically I'll use the C-arm to get my level and the ultrasound to guide my needle into the joint, or more the medial branch nerve, which is my typical target. The The nerves will run over the bone by the posterior tubercle or the articular pillar to innervate the joint and the muscles. Typically, 2 medial branch nerves will innervate every facet joint. Here's an image of the medial branch nerve. It's hyperdense, hyperlucent, and you see it over the articular pillar. Okay. If you come from posterior to anterior, you're just coming in like you're doing a trigger point, and the needle is landing on top of the bone, and you're getting anesthesia here. I've done radio frequency with this approach as well, and it's helped quite a bit improve accuracy. I also use a CR. I like to use both. When you turn your probe longitudinally, you'll see the medial branches line up as well in the groove on the bone. This is what the nerve looks like. I typically do not block it in this location because I find you need to come out of plane to get a good, it would be difficult to come in plane just because of the orientation of the probe and the neck. On some patients it may be fine. On some patients with shorter necks, it could be quite challenging. Now moving down to the lower back, caudal epidural steroid injections under ultrasound. So the indications are lumbosacral radiculopathy. It's ideal when there's hardware in the lumbar spine. Caudals are great because you're less likely, you can get a dural puncture, but I think you'll be less likely to get the dural puncture and headache. So if you have a patient with failed back surgery syndrome, it's not a bad idea to do a caudal. It works really well for patients with spinal stenosis as well. And here's a little video. You're getting a cross-section of the sacral cornu. We call it the frog sign. You see the 2 eyes of the frog. And the sacrococcygeal ligament is over there. You turn the probe, so you're oriented longitudinally. And centrally, you'll just see the ligaments. If you go parasagittal, you'll see the cornu. So this is a nice central view. Here's a cornu, so you're parasagittal. You're a little bit off to the midline. And I'm just anesthetizing the tissue, but I'm not going to insert it like this because I'll hit the bone. So now I went more midline, and you don't see the cornu anymore. And the needle's being guided down to the sacrococcygeal ligament to perforate and enter into the epidural space. You'll note here the needle touched the bone of the canal, and I'm redirecting. I'm increasing my angle and perforating the ligament into the epidural space. I'm going to aspirate and inject, and it's a nice procedure, very safe. You see some retrograde spread backwards. That's what you see with a C-arm also when you do these cases with contrast. I do this in the office these days when patients, I mean, I've been doing this for a while. I typically prefer fluoroscopy, but I think this is just as safe. It may not be just as accurate in terms of knowing where your medication spread. However, this is a procedure that I gave 40 milligrams of depomedrol or Kenalog or methylprednisolone and 9 mLs of saline. So you get up to the lower lumbar levels. Minimal risk. Patients do great. The thing is, patients these days have to have a COVID test to go into the fluoro suite in our quad A room or into the AmSurg Center. And if they don't have a COVID test, but you're allowed to do a shot in the office where they're getting minor procedures, this could be something that you could consider. Of course, you have to be very sterile and careful when you're doing these procedures under spine procedures under ultrasound. Speaking of which, S1 foramen injection, a selective nerve root block or transforaminal injection. You can see the foramen. Here, sometimes you see just a gap in the bone where there's nothing here white. Here you see something white. It could be either the lateral branches, lateral sacral dorsal rami, or beginning of a cluneal nerve. But this is a sacral foramen. Here's the sacrum, here's the sacral alar, and up here would be where your dorsal ramus is. You can see just the orientation of the probe. Moving a little bit caudad, you could see S1 and S2 foramen. You could do a longitudinal, a transverse view, excuse me, and get the PSIS, and medial to that, the foramen that you see is usually S1. As you can see here, PSIS, S1 is medial. And the superior cluneal nerves are here. The superior cluneal nerves are really something that we've missed. I mean, when I wrote pain exam, this was not on pain exam. When I been updating it every year since 2007, I never even thought about these nerves since med school until I started doing peripheral neuromodulation. And now I'm kicking myself for how many patients I missed with superior cluneal neuralgia. And I think most pain doctors who are more than a couple of years out of training are also have missed this and should be kicking themselves. It's that patient who presents with pain in the lower back, maybe just medial or on the posterior superior iliac spine or over the iliac crest in the central region or even lateral region, that we all thought had a trigger point. And we did trigger points and they got better and we didn't think much of it. But there are nerves that innervate the gluteal muscles, sensory nerves that pass from the dorsal rami of L1, or actually T12 to L4 and even L5 in some case reports, and innervate this area. The pain is axial back pain, usually in the gluteal region, the buttocks, can radiate down the leg. Whereas with lumbar movement, posture changes. There's a trigger point over the posterior iliac crest corresponding to the nerve compression zone. Patients can have numbness, radiating pain in the area of the nerve. It's a Tinel's, right, when the trigger point is compressed. And a injection of lidocaine, maybe 1 ml, 2%, will relieve the problem. So once again, this is where the superior cluneal nerves run, the inferior, and you have the middle and the inferior. So for the diagnostic criteria, you're going to have the pain in the crest by the buttocks, change the posture, the compression point, Tinel's, and relief with the nerve block. And these are those points I'm talking about. We've all seen patients with these points, but most of us dismissed it. You could be easily confused with gluteal trigger point, facet pain, gluteal trigger point again, sacroiliac joint pain. It could be any of these, okay? So I recently was asked to write a chapter in a book with Dr. Ala Abdul Saeed, and this is Dr. Trescott's book on peripheral neuromodulation, and the chapters I'm writing on is superior cluneal nerve and middle cluneal nerve. This is a big deal because I have people for 6 years I've been treating, no relief, and I've done everything on them, and now they're getting relief. In fact, cure. It's really helping them. So this is something, if you are a pain doctor, pay attention, and if you're an anesthesiologist, it's just good to know. Okay, here's just the superior cluneal nerves originate from the dorsal rami of primarily the upper lumbar spinal nerves. The nerves cross the iliac spine to innervate the skin and subcutaneous tissue over the gluteal region. The nerves extend as far as the greater trochanter, and the area of innervation may overlap anterolaterally and the iliohypogastric and lateral femoral cutaneous nerves. A reliable nerve block technique may have the application in the management of postoperative hip pain surgery as well as other clinical conditions, for example, chronic low back pain. This superior cluneal nerve block will anesthetize the skin posterior to the area innervated by the iliohypogastric and subcostal nerves, improving anesthetic coverage for hip surgery. A diagnosis of superior cluneal nerve and medial cluneal nerve entrapment may be made by palpation of the iliac crest or long posterior sacroiliac ligament, resulting in marked tenderness and provocation of symptoms, and pain relief with local anesthetic injection. The superior cluneal nerve tender point on the posterior iliac crest is approximately 70 millimeters from the midline and 45 millimeters from the posterior superior iliac spine. And the osteal component of this tunnel is the rim iliac crest, and the fibrous component is the tough thoracolumbar fascia. Now that's the medial branch of the superior cluneal nerve. Now this is a patient who originally had a sacroiliac joint injection as well as gluteal trigger points, gluteal bursa injection without any long-term relief. And on exam, she did have a positive Tinel's near the iliac crest, right where my needle is and where I'm working. And what I did first is a longitudinal view, and I identified and anesthetized a medial branch of the cluneal nerve, and now I'm doing a cross-sectional view with a transverse approach. And the nerve is quite small and difficult to identify, and the best way to identify a positive nerve block is to have the patient report response with only 1 or 2 mLs of lidocaine 2%. This patient did very well and is going to go on to peripheral neuromodulation. This patient had a laminectomy and axial pain to the right side, radiating to the buttock and hip. He was unwilling to come for a fluoroscopic facet or medial branch nerve block, and in the office I performed a superior cluneal nerve block at the higher lumbar regions where his trigger points were, that were radiating down to the lower back, buttocks, and side of his hip. Upon going towards the more superficial hyperlucency, the patient reported concordant pain. Upon redirecting the needle and depositing 1 ml of lidocaine 2% at the deeper trigger point or hyperlucent spot, the patient reported pain that correlated exactly with the superior cluneal nerve distribution. It radiated from this region down to his buttock and side of his hip. Patient reported immediate pain relief and is to be followed up in the office for possible repeat injection or maybe peripheral neuromodulation in the future. So you could also ablate the nerve in these patients. This is another patient who had failed back surgery syndrome, spinal cord stimulator, responded to RFA, responded to epidurals, responded to the stim for his leg pain, but not his buttock pain. He had a lot of axial buttock pain bilateral. And here I'm doing here I'm putting in a peripheral nerve stimulator using the needle. I'm first scanning the spinal cord stimulator lead, which is this hyperlucent structure with a hypoechoic shadow behind it, okay? And I'm running the needle deep to the wire from the stim, deep to the lead, towards the middle branch, the medial branch, not the middle branch, that's different, of the cluneal nerve. And here I'm putting my needle. I'm injecting the nerve. And he got very good relief with this block, and he's actually being neuromodulated right now. He has an implantable system. There's another patient who had just
We're going to anesthetize the lateral branch of the superior cluneal nerve.
Runs
Patient had a fall and is complaining of pain in the region. The cluneal nerves originate from the dorsal ramus of the upper lumbar levels, and they run down towards the buttock and give branches that innervate the region near the iliac crest as they pass over it, as well as even to the lateral aspect of the hip.
One is the iliac crest.
So the bone shadow here is the iliac crest. I'm scanning from side to side to identify the nerves. We're too deep, so I'm going to reduce the depth. And right here is a lateral branch of the superior cluneal nerve, which is right over the patient's tender spot. This is a cross-section of the nerve. These nerves pass through a fibro-osseous tunnel as they cross over the iliac crest and descend. A little pinch. Is that the spot?
I think so.
And give the rest of the injectate. Come to the other side of the nerve.
This is therapeutic. You can see I'm using a steroid here.
And that's the lateral branch of the superior cluneal nerve over the iliac crest.
Okay, the middle cluneal nerve, I should say middle, not medial, arises from the posterior ramus of sacral nerves S1 through S4. Identify the posterior longitudinal, the long posterior sacroiliac joint ligament, PSIS, the sacrum, and the nerve is medial to it, or running through it, I should say. It comes from medial to lateral. It also sends branches over the iliac bone towards the gluteal muscles. Here's your ultrasound orientation for this nerve block. So S1 foramen and scanning lateral to the foramen, you could find a structure right above the foramen that could be the nerve. Very small. Okay, this requires a lot of imagination, honestly. I am labeling this a nerve based on my knowledge of the anatomy. I've seen cadaveric dissections of this nerve, and I really encourage you all look for yourself to see this. This nerve can be RF'd, can be neuromodulated, can be blocked. You can do a lot of this stuff for this, and this will help with refractory buttock pain. They've done studies on patients who've had their sacroiliac joints injected, and those who didn't respond, they just injected near the long posterior sacroiliac ligament, and the rest of them all got relief. This ligament can impinge the medial branch, causing pain. Typically, when doing the diagnosis, you want to palpate the ligament or medial to it. The trigger point is 35 millimeters caudate to the posterior superior iliac spine. This is the compression zone, and you want to anesthetize this region. Patients will get pain relief when you block the nerve, and as you can see here, this is just like SI joint pain. It's very confusing sometimes. So if you have those patients not responding to SI joint injections, consider the middle cluneal neuralgia. Inferior cluneal nerves come off. They're also known as the posterior femorocutaneous nerves. I don't have slides yet on this one. I have not been blocking this one. That's why. It's less commonly blocked in my practice. Maybe in other practices, maybe you've seen it more. But basically, the nerves innervate the inferior part of the buttock. And I just started doing these, but I still don't have good images for you yet. The sympathetic nerves, okay, the most important one is ganglion impar block. I'm not sure if you guys already saw the video, but I have it here for you. I'm going to just show it to you before we close up for the day. This is what we're looking at. The ganglion impar is anterior to the coccygeal bones, posterior to the rectum. So coming to the page here, and I'm going to talk over here to their targeting. Here I'm using the X-ray as well. You see the spread is more back. There is a spread on the side. Red. And here we will answer showing the process. So that's the whole course for today. As time goes on, I'm going to be adding more and more and varying up the course a bit. So if you're interested in doing this again, let me know. I could give a discount to anyone who comes back. I'm also going to be changing it up. So we're going to do regenerative medicine as well as the fascial plane blocks. I'll do a little more of the pecs, the serratus, maybe rectus spinae, and a bunch of others. And I hope you enjoyed. I hope that you check back with us frequently. Make sure you claim your CME credits. Do you have any questions before we close up? Or any questions, complaints, or requests for the future? Okay, how do I code the cluneal nerve block? The cluneal nerve block is a 64450 other peripheral nerve block code. If you're doing a ablation, I would code 64640. If you're doing percutaneous stimulation, 64555. And that goes for both the middle or the superior nerves. There's another question: how long to use PRP after I do a diagnostic block? That's an interesting question. Well, you don't need a diagnostic block for PRP. If it's RFA you're referring to, well, you just need to have a follow-up or at least a document in between the block, documenting response, and then afterwards you can do the lesioning. Okay, well, if there's no other questions, I wanted to thank you all for joining. I hope you enjoyed, and shoot me an email if you have any recommendations for the future. Take care and stay safe.